Good morning and a warm welcome to all the dignitaries present here. I'm Sri from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event, hosted by the Indian Society for Prenatal Diagnosis and Therapy, and the focus of today's session is unlocking the code, genetics, and reproductive health. So let's begin today's session, in which I would like to introduce Dr. Prerna Kishan ma'am to take over. Let me share a CV deck first.
Hello.
Yes, ma'am. If you want to say anything. Okay, so let me introduce Dr. Prerna ma'am. Ma'am is zone leader of YTPC Foxy, Yuva Coordinator of Foxy, member of Breast Committee Foxy, Zonal Joint Secretary of IMA WDW, Honorable Secretary of ISOPAT DIB Chapter, Chairperson of IMA Mission Pink Health Assam, Chairperson of IMA ASB Shyam Project, State Coordinator of IMA Assam Safe Motherhood Committee, and Executive Member of INSAR, Executive Member of NAISAR, Patron Member of PCOS Society, Executive Member of Indian Fertility Society, Assam. So without much delay, ma'am, I would like to hand over the session to you now. Please proceed with the talk. Prerna ma'am. Over to you, ma'am.
Thank you, Shreyosi, and wishing you all a very good morning. And I'm immensely honored to welcome you all to this one of its kind, unique initiative by the South Asian Federation of Obstetrics and Gynecology in collaboration with the Indian Society of Prenatal Diagnosis and Therapy. This masterclass on unlocking the code in genetics and reproductive health. And what a beautiful Sunday indeed it is, with a star-studded program of stalwarts from across the globe to enlighten us on very little aspect of genetics and reproductive health, delving from the basics to the very recent advances in this very promising arena. I would like to also introduce my co-MOC today, Dr. Naima Sharim Haq from Bangladesh, Dhaka. She is a professor in charge of JH Sigdar Women's Medical College Hospital and has become a very, very good friend and a charming personality in a very short span of time. Welcome, Dr. Naima, to the show. And at the very outset, I'd like to take the honors to welcome the brainwave and the steering force behind the entire program, our very beloved and revered ma'am, Dr. Jaideep Malhotra, none other than whose name itself is an inspiration, and a super achiever, an apt academician, a social health activist, a philanthropist of international repute. Ma'am needs no introduction. She is the role model of so many of us youngsters and has been working for the upliftment of women's health across the globe for almost more than 3 to 4 decades now. Ma'am holds numerous prestigious positions in various international and national organizations, and naming a few will be customary. In the stature of the MD of Rainbow IVF Agra, ma'am holds the position of past chair of FICU, FIGO REI, and also the immediate commute past chair president of almost all the ACE organization of including FOGC, ISAR, Aspire, IMS, SAFOG, ISPAT. And ma'am is president-elect of INSAR and has also numerous publications and awards to her credit, of which FRCOG honorary is worth mentioning, and also the Nepal Samman Awards. Ma'am has a number of publications, and ma'am has many firsts to her credit. So it is something which we all need to know, that ma'am has been widely acclaimed for her one and all app, that is a time out app that is widely acclaimed throughout the nation, and the list of achievement of ma'am is infinite. And we can just say that she's a pathfinder to us, and we can also look up to her whenever it is required, today and in the years to come. We are so very honored to have you, ma'am, amongst us, and the dais is all yours for the welcome address. Dr. Jaideep Malhotra, ma'am.
Thank you so much, Prerna. Thank you. And I'd like everyone to mute themselves, please. Dear friends, a very good morning, India. It's such a great pleasure for me to be, at the helms of affairs for this wonderful masterclass, for which a lot of requests had come from all over the region as far as South Asia is concerned. And I am sure that it's really going to benefit a lot of our youngsters too. Who are you? What makes you so unique? is a question which we normally ask ourselves. And this is what our genetics is all about. Why are some diseases running in the families? We do understand there are lots of cancers and diabetes and all those which run in the families, and it's sometimes very difficult for us to understand. And as a treating physician, learning a lot about family history and the family health and what diseases are running in the future actually gives us a lot of insight into understanding the disease process, and also how we can actually prevent these diseases from recurring in the future generations. And of course, we will definitely understand much, much better. And once we understand much better, we are going to really treat also better. Similarly, it's about infertility. We normally are just looking at all kinds of solutions on what can be done if such a problem happens, but we never delve into why this has happened, and is there a way of preventing these problems which are running one after the other from one generation to the other, and having repercussions on the future health. So today I feel very, very proud that this masterclass is going to really of our understanding and show us a different way of treating people. Now, what is important is that we are a good physician. We must treat the person as a whole and only the disease. And the whole purpose of this masterclass is all about that. And I am very, very proud today that two premier organizations have joined hands together. We have the SAFOG, the South Asian Federation of Prenatal Diagnosis and Therapy. Both of them have joined hands together to provide us a lot of clarity on the various topics which we are really going to, delve into in these next 4 hours. I'm sure all of you are going to have a great, enlightening, and exciting time in these 4 hours. And now it gives me a proud privilege to invite the president of SAFOG, none other than Dr. Shyam Desai. Dr. Shyam Desai is a very well-known figure all over the region. He has been the past president of FOXY, and right now he is heading our South Asian Federation of OBGYNs. And the next, I would like to invite Dr. Saurabh Dani. Dr. Saurabh Dani is the current president of ISPAT, and he is a consultant OBGYN in the various hospitals in Mumbai, and is also has been the past president of the Association of Fellow Gynecologists in Mumbai. Has got very special interest in high-risk pregnancy and newborn screening. So I'd like to start with the Vandana first, and then we will have address by Dr. Shyam Desai and also Dr. Saurabh Dani.
Om Saraswati Namo Namah, Ma Saraswati Namo Namah, Vidyadayini Namo Namah, Hansavahini Namo Namah. Om Saraswati Namo Namah, Ma Saraswati Namo Namah, Vidyadayini Namo Namah, Hansavahini Namo Namah.
Dr. Shyam Desai, please.
Thank you, Jaideep, for that introduction. Today, we are going to have a webinar, which is an extremely informative webinar. It is long overdue that we sensitize our delegates and our members to the fact that genetics plays such an important part in our day-to-day lives, and especially in those of us who are treating obstetric patients. Now, genetics is, as you know, something which is inherent, and it can cause problems because of various abnormalities in the chromosomes, and it can cause problems in infertility. It can cause problems in reproductive health to the extent that it can cause reproductive health failure. It can cause also difficulties in the newborn, And therefore, we are going to have lectures which are going to be elucidating the various aspects of genetic health. Now, I remember it was almost about 25 or 30 years ago that we had one of our own members who was specializing in genetics, Dr. Hema Purandare in Mumbai. And she was also a very important part of the ISPAT with whom we are collaborating today. And she was the one who initiated the entire the concept and the treatment of genetic problems. And Dr. Hema Purandare has been very, very active in the OBGYN fraternity in Mumbai. Now, genetics can also cause various problems such as trisomy and can cause Edwards syndrome. And therefore, even as a prenatal diagnosis, a screening test that has been advocated, that is the dual marker and the triple marker, and now the quadruple marker. And these are entities which now should be carried out in all women at 12 weeks and at 18 weeks, so that we are able to pinpoint and more or less say accurately that the patient has no genetic or the fetus has no genetic problem. Now, the excellent lectures that have been outlined by Dr. Jaydeep Malhotra and Saurav Dani, who is also a very, very active advocate of genetic health. And I wish all the participants, I'm sure they will be giving us extremely good information. And I wish this webinar a success. Thank you, Jaydeep.
Thank you, Shyam. Thank you so much. And please stay back because you'll be chairing the next session. Dr.
Okay.
Saurav Dani, please.
So, good morning, everybody from Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Sri Lanka, Pakistan. Dr. Shyam Desai, President SAFOG, Dr. Jaydeep Malhotra, convener who has really orchestrated this whole program and the collaboration between these two societies, and Dr. Manjeet Mehta, who is the current Secretary of ISPAT. So it's a privilege to welcome you all to this pivotal discussion on genetics in reproductive health. So at the heart of every life, there is a genetic code that shapes our future and the well-being, And today's advancements in genetics are such that we can offer or promise better health to everybody and better reproductive outcomes. And a lot of it can be done by early diagnosis and treatment and genetic disorders, and we can have a personalized care, which is also possible. So, however, with this progress, there comes a shared responsibility, to ensure that there is equitable access available and there is an ethical application and there is a global education. So it's a wonderful thing that today at least a few countries in our region are coming together to create this global education. We are not only unlocking the code of life, but we are also opening the door to a healthier futures for all. So this symposium gathers leading minds to explore the latest innovations and their impact on reproductive and neonatal health. Together, we can harness the potential of genetics to improve lives, ensuring that the power of this science reaches every community, regardless of the border or circumstances. I would like to thank and welcome SAFOG and ISPAT Symposium and all the members of the both associations, and look forward to an insightful discussion ahead.
Thank you, sir. Thank you, Sam Desai, sir. Thank you, Saurav Dani, sir. And Jaydeep, ma'am, would like to say something?
Yeah, well, let's start with the next session. The whole program has been curated as understanding genetics which is before pregnancy, or understanding the genetics. And let's invite our first speaker. And I invite both the chairpersons, Dr. Shyam Desai and Saurav Dani, to introduce our first speaker.
I welcome Dr. Narendra Malhotra, who is the first speaker in this webinar. Dr. Narendra Malhotra is a very senior executive committee member of the South Asia Federation. Most importantly, he is the Director of International Relations, which is a very, very important post because it coordinates or helps to bring together academic activities and various projects in the South Asia Federation. Dr. Narendra Malhotra is well known to all of us. He has been the past president of FOXI. He's also been the president of the ultrasound organization, and he's now also involved deeply with the ultrasound school, and therefore he's the apt person who will be able to deliver this particular talk. It is on genetics in infertility, and I welcome him to give his address.
Thank you, Dr. Shyam Desai, for the kind words of introduction. A very, very good morning to all of you on this Sunday morning, and a great academic feast which we are about to witness in the next 3 or 4 hours. So I am going to take you through what we call as the genetic causes and future directions in recurrent pregnancy loss. So that let's start with the definition. Now, the 3 major organizations of the world, ESHRE, RCOG, and ASRM, define RPL a little bit different. So let's the ESHRE first, Society of Human Nutrition. Pregnancy should be documented by urine or serum beta HCG. More than 2 losses, ectopic and molar, are not included and need not be consecutive. The RCOG, the Royal College, says more or equal to 3 consecutive or non-consecutive losses, not required to be intrauterine. So they could be ectopics also. And ASRM says more than 3 losses proven by ultrasound or histopathology for epidemiology. So that's the definition. So first, or more than 2 losses for clinical evaluation. Now, when we look at RPL, then there is primary, secondary, and tertiary. The primary means multiple losses in a woman with no previous pregnancy reaching a viability of 24 weeks. The secondary means multiple losses in women who have already had a pregnancy beyond viability. So 1 pregnancy over 24 weeks. And the tertiary RPL is multiple pregnancy loss in between normal pregnancy. When you look at the etiology, the maximum cause of RPL is idiopathic, and followed by immunological, endocrine, anatomic, and then genetic, which is 3 to 5%, and last is infections. So we are talking whenever we say the RPL risk factors, we just open our palm and say there are 5: demographic, anatomical, immunological, endocrine, genetic. Please note the infections don't come here. So no torch infection to be given more importance. The genetic links can be genetic chromosomal anomalies, which I'll come to you later. A little bit of genetic links. Established causes of RPL are with inherited thrombophilias, acquired thrombophilias, thyroid dysfunction and autoimmune thyroid disease, PCOS, prolactin disorders, factor V lean mutation, prothrombin gene mutation, protein S deficiency, protein C deficiency, and antithrombin 3 deficiency. So these are the thrombophilias genes which are associated with recurrent pregnancy loss. Now, whenever we say that inherited thrombophilia are associated, so the question comes, should we be testing for them or not? Now, when routine testing and when to test is not required. These tests for thrombophilias are indicated only if there is history of inherited thrombophilias in first-degree relatives, or there is a history of VTE, venous thromboembolic phenomena, in a non-recurrent setting, such as surgery. Recommendation for women with RPL, we suggest not to screen for hereditary thrombophilias unless in context of research or in women who are at risk of thrombophilias. So that is what the evidence says. So no need to test them routinely. Let's come to the genetics. The genetics and product and period of gestation. 90% of product of conception from losses into 0 to 6 will show aneuploidies. 50% of sporadic losses occurring at 8 to 12 weeks, 8 to 11 weeks, will show some genetic abnormality, aneuploidies. 30% in tissues which are lost at the 16 to 19 weeks gestation, and 6 to 12% on 20 weeks. So if you see, the earlier loss before fetal heart rate is more indicative of a genetic cause. Once the fetal heart rate is established on ultrasound, the risk of aneuploidy is only 5%. So that has to be kept in mind, and also kept in mind that sporadic losses, it will be in 50%. Now, what happens when we talk about genetics of RPL? It could be from the parents, that is parental, or it could be in the embryo. Now, parental could be reciprocal translocation inversions at the chromosome level. We'll talk about each one of these a little bit in detail. And the other is the embryonic POC, product of conception. Increased pregnancy loss in carriers of reciprocal translocation and inversions as compared to Robertsonian translocation. We have to understand what is Robertsonian translocation and what is reciprocal translocation and inversion. And we'll just show you what are these. So there will be losses will be more when there is a reciprocal translocation or an inversion. So the report has to be seen properly. So what are the genetic abnormalities we see in a fetus or a product of conception in these abortus? Trisomies 58 to 21%, especially of 15, 16, 12, 22X. Remember the trisomy 21, 18, and 13, which is Edward, Patau, and Down syndrome, do not cause recurrent pregnancy losses. They may be sporadic, and they are usually born live and they have genetic problems. So it is these trisomies 15, 16, 12, 22, 11, or 10, or sorry, X, which are the cause. Monosomies at 21 and X, most common in sporadic than in RPL, and mostly these are aneuploidies. Structural anomalies 7 to 9%, as you see, they can be deletion, duplication, inversion, insertion, and translocation, as you can see here, which we'll just show you in details. And polyploidies, that means more than 2 chromosomes, that is complete polyploidies, 2 to 9. Age and aneuploidies. Now, age-related aneuploidies are because of the ovarian quality and the ovarian aging egg. So euploidy rate is independent of the number of blastocysts obtained, but not from the age. So the effect of maternal age on a euploid rate, that means a normal embryo in a large cohort of embryos analyzed with 24 chromosomes with a single nucleotide polymorphism based on PGT, PGS, showed that the age-related problem if ovarian quality is there. Let's come to the parental factors in a little bit of detail. So genetic abnormalities 4 to 5%, 3 to 5%, RPL 3 to 5%, abnormal karyotype in parents is seen in 1 to 9%, chromosomal abnormality in single sporadic miscarriage is about 50%, chromosome abnormality in subsequent miscarriages preceding the RPL is 39%. What are these types? The chromosomal anomalies can be in the number and can be in the structure. Number, as we told you, aneuploidies, which are autosomal or sex chromosomal, and monosomies, trisomies, or tetrasomies. Polyploidies, triploidies, or tetraploidies. All are 4, as you can see in the picture here, this one. Structure are gross and micro. The gross is translocation, which could be reciprocal or Robertsonian. Inversion, which is paracentric or pericentric, depending on where it is from the center. Deletion of one part. Insertion, that deleted part is inserted somewhere else. Rings around the chromosome. And isochromosomes. That means similar chromosomes lying. Mainly, we are worried about reciprocal Robertsonian inversions and deletions. What is inversion? See, here is a normal Y chromosome. It should be like this, but it is inverted. What was upper has come down. So if it is inverted, inversion, that is known as inversion. Translocation is a portion of a chromosome transferred to another. So this portion of the chromosome, which is here, is transferred to another chromosome. Robertsonian translocation affects the acrocentric chromosome. That is the narrow region where both the halves of the chromosome join near the very end of the chromosome. Acrocentric fuse together with joins two arms into one. And the acrosome translocation occurs only at 13, 14, 15, 21, 22. So common translocations are 13 is translocated with 21, 14 is translocated with 21, 15 is translocated with 21, and 21 is translocated with 22. As you can see here, in the red and the blue, and the red and the blue, and the red and the blue. Now, inherited balance translocation, here you get the normal chromosome. So this portion is 4 and this is of the 22. When it is balanced, that means it is balancing, equal. When it is balanced translocation, it's equal. When it is unbalanced, that means one portion is smaller and one portion is bigger. So 4 to 22, 4 to 22, bigger and smaller. And this is known as trisomy 4P because of the P arm. And this is Wolff-Hirsch syndrome, which is the unbalanced translocation. Now, when you draw a pedigree of this, the parents can be normal and one is a translocation carrier. At 21, 14 is a carrier. And the gametes will be distributed as normal, carrier, affected or not. While from the normal, it will be normal. So these people will yield a normal child. They can have a translocation carrier child. They can have a monosomy 14, which will abort. They can have a trisomy 14, which will abort. They'll have a monosomy 21, which will abort. And they'll have a translocation downs, which may live. So the normal and translocation downs and a carrier will live. That's why it is important to study for Robertsonian translocation. Now, why are these more important? The genetic factors are derived from parental chromosome abnormalities. They recur in the next pregnancy, so intervention is required. While the genetic factors in embryo are de novo, while division, and they off to a chromosomally normal parent. So there'll be no recurrence, no intervention. That is why probably for counseling, a genetic test may be required. What are our concerns? Our concerns are whether to test the genetic pregnancy tissue, whether to test parental genetic analysis, or whether to do a pre-implantation genetic testing. So should we evaluate for genetic testing or genetic causes in all abortions? Now, routinely, everyone says it is not recommended and carried out after the individual assessment of the risk and diagnostic work. Genetic evaluation should be offered to prior child with congenital abnormalities, family history of offspring with unbalanced chromosome composition, translocation detected at the analysis of embryonic tissue, which we just showed you. So there it is required. Now, this was when they were doing only karyotype. When the microarray and the cytogenetics came, then probably the guidelines are likely to change. What about embryonic tissue? As the number of miscarriages increases, the risk of euploid pregnancy loss increases. So cytogenetic analysis should be performed on the product of conception in the second and the subsequent consequent miscarriages. And we will advise that you do a microarray here, a CMA, and not a plain simple karyotype, because that will yield you a better result. So routine testing of POC again with an abortion is not recommended as per all the guidelines, which we'll show you. But this was when it was only karyotyping. Now with microarray, probably the guidelines will change. So Eschere in 2022 says the genetic analysis of pregnancy tissue following a pregnancy loss is not routinely recommended, but it could be performed because you can explain to the patient. And so conditional recommendation is there, which is 2+. ASRM in 2012, this was an old guideline still going on. They say it was not recommended, and this was based on karyotyping and not on array CGH. With array CGH, probably the ASRM is going to change its guideline. So that is it. The RCOG says that increased diagnostic yield is 90% and cytogenetic analysis should be offered in the POC of the third or the subsequent miscarriage at second trimester. The evidence quality is 2, the strength is D. So it confers a significant diagnostic, psychological, auditing, research advantage. So it is recommended for all that. For parents, ASRM says recommendation that parents should undergo karyotyping in order to detect balanced structural chromosomal abnormalities. So we want to know Robertsonian or not. So it's worth mentioning that this was all recommendation in 2012 was done, as I told you before, on G banding karyotype analysis. Today we have microarray, so that it could be more effectively changed. ESHRE in 2022 recommends parental karyotype out for an individual to assess the risk and diagnostic purpose. Again, conditional plus two evidence. So that is there. ESHRE also recommends that parental karyotype can be recommended in 3 cases: birth of a child with congenital anomalies, offspring with unbalanced chromosomal abnormalities, detection of translocation in the pregnancy tissue. The RCOG says the recurrent miscarriage parental peripheral blood karyotype should be performed in couples in whom testing of pregnancy report there is an unbalanced structural. So if you have a structural abnormality in the POC, the parental testing should be done. Now, how do we propose? First pregnancy loss, nothing. Second pregnancy loss, chromosomal analysis of POC plus microarray. Microarray is more important because you might not get a G banding karyotype because the cells are dead if it is missed about, and it will not yield to a karyotype. It can be aneuploidies. It can turn out to be unbalanced. It could be normal euploid. So if it is aneuploidy, no further testing. If it is unbalanced chromosomal translocation, then you do parental karyotype. If it is a euploid normal, then you do the other recurrent miscarriage workup. What test to give? Karyotype, FISH, NGS, CMA, sequencing. So what is recommended? Genetic testing for POC, you do a conventional karyotype. Can we do FISH? Can do multiple ligand-dependent probe amplification. Array comparative genomic hybridization is probably better. SNP and next generation sequencing may not be required unless you are suspecting a single nucleotide disease or a single gene disease. So we do a karyotype which is intense, and there will be cell culture failure if it is dead POC, and there will be maternal contamination. Fluorescent in situ we can do out of 24 probes, only 5 or 6 are done, otherwise it becomes very expensive. So most recommended for genetic analysis of POC is array-based comparative genomic hybridization with ACGH or CMA. Next generation sequencing and SNP test are currently no evidence to provide any additional benefit. So CMA is what is recommended on the POC by all ESHRE, RCOG. ASRM has to change its guidelines. Then what are finally the choices for these couples? The choices for these couples are in the next pregnancy to have a PGT, pre-implantation genetic testing, SR, M or A in unexplained. Aneuploidy, single gene, or so PGTA is done when the age is 35, 38, recurrent implantation failure, recurrent pregnancy loss, pregnancy with chromosomal abnormalities, severe male factor, and good prognosis in patients mostly who are going to go for a single embryo transfer. The goals are that we want to increase the pregnancy rate and implantation rate and a take-home baby rate. So this is how it is done, and a single cell is taken out and it is tested. In 2012, genetic counseling is very important, which we are also emphasizing. When one of the partners has a structural genetic abnormality, PGT, amniocentesis, chorion sampling are the options before implantation and during pregnancy. ESHRE says that all couples with result of an abnormal fetal or parental karyotype should receive genetic counseling. So genetic counseling is universally accepted for all. And all couples with abnormal fetal parental karyotype should be informed that these are the options available. You have an option of pre-implantation genetic diagnosis, SR, A, and M, and or you get pregnant and then we do a testing by NIPS and by chorion sampling or by amniocentesis. So that is counseling is required. Similarly is the guideline with the RCOG, which is the most recent guideline in 2023. But the risk of PGT-SR, PGT-A has to be informed of the embryo biopsy, and also the evidence regarding the improvement of reproductive outcome should be informed, because a reproductive outcome may not dramatically increase or improve. Now, does pre-implantation genetic diagnosis improve the reproductive outcome? So this is a study, and say because of the limitations of the study, we cannot randomize the control studies, and we cannot right now say that this will improve in all the cases. But in reciprocal translocation, Robertsonian translocation, this might be, you might see a slight improvement in the reproductive outcome in these pregnancies. That was all the papers and the evidence for it. Lastly, what is the future? You can detect single gene and musculoskeletal gene defect for RPL. You can do immunological gene defects and unexplained RPL, that is HLA-G, polymorphisms at P53, P72, LIF, FASL, VGEF. We can put the testing on new platforms like NGS and SNP array and whole genome sequencing. We can do molecular-based techniques or AI models for large morphokinetic database to determine the accuracy and to predict the risk of miscarriage. The AI will do for us. And of course, NIPGT for PGTA in unexplained RPL. So when you do a SWOT analysis for it, the strength, weaknesses, and analysis, the strength, opportunities, and threats, the strengths are that this genetic testing will aid in diagnosis and prognosis. Weaknesses that we are not yet sure of all the genetic causes of RPL. The opportunities is that the newer testing platforms are coming. And the threats is that commercialization to the patient, and the patient, all patients will be started offering genetics, and the cost will go up. So a proposed genetic algorithm would be completely based on ASRM, X-ray, RPL. If the results are abnormal, treat accordingly. If the result is unbalanced, treat accordingly. But PGT in the next, if the result are normal, then you go ahead with it. So ladies and gentlemen, to conclude, cytogenetic abnormalities occur in 2 to 5%. Cytogenetic analysis with routine investigations diagnose over 90% of couples who are having chromosomal anomalies. Genetic evaluation, even without therapeutic benefits, can be offered, provide crucial psychological support and counseling. The current guidelines recommend CMA for POCs, followed by parental karyotype if you find a structural defect. Genetic counseling is essential for all these couples. PGT-SR for known translocations, PGT-A for unexplained RPL are potential options, though the evidence for live birth rate is still limited. And there is a lot of ongoing research to enhance the outcomes. I thank you very much. Thank SAFOG, ISPAT for organizing this wonderful genetics update. And we hope that healthy children to healthy nations will be born. Remember, it's all in your genes. So you got to know your genes, and you got to discover yourself through your genes. Thank you very much.
Thank you, sir, for a wonderful presentation and a wonderful summary of the topics and the whole perception of how genetics is and how it shapes the future. And it's wonderful to understand, and especially the routine obstetricians who do not encounter day-to-day genetic problems. For them, it was a very lucid presentation to really make them realize how the way forward is and what are the opportunities available. So thank you again for a wonderful talk. And do we have the next speaker ready?
Are we allowed to ask some questions? No?
Yeah, you can ask.
You can ask, but I'm not answering.
Actually, the next talk will answer quite a few questions.
There are a lot of
It's in
geneticists
continuity.
sitting here who are going to answer. Manjeet Mehta, Veronica, they will answer.
Yeah,
No,
so
you
a
are
lot of
welcome
it
to
will
ask.
be covered in the next talk. I think we
You
could
can pass
start
it
with the
on.
next talk.
You can pass it on if you want, no problem.
So if the next speaker does not answer your question, then I think you will have the
We
right.
will ask. Yeah, let us listen to the second talk before we ask. It's all right. Sure.
So can you present the CV for the next speaker, please? Who is there for clarinet?
Shreyasi?
Yes, ma'am.
Please, please display Veronica's CV.
Yes, ma'am. Here it is.
Yeah, thank you. So our next speaker is Dr. Veronica Arora, and she's a clinical geneticist at Gangaram Hospital in Delhi. You can read the details of her CV in front of you. And I would like to add a very special note that she's a very important upcoming team member of our ISPAT team in India. And I'm sure that she's going to bring a lot of uh, her experiences and her influences into shaping this path in the future. So with that, Veronica, please go ahead, and we hope that you can answer all the questions that people have in your presentation.
Yeah, Veronica just got disconnected. She's connecting again. So in the meantime, we can utilize this time for some questions.
Yes, I think Dr. Meenu Agrawal's question has to be answered.
No, I just, that was such an excellent talk on the RPL. Every time you listen to RPL, you always again have some take home message which you carry to the office with you. I just wanted to ask, when you send the sample for karyotyping or microarray for products of conception, do you ask your lab to also store it for future use, or you just one test and that's it?
So I think Dr. Narendra Malhotra is here. I think
Ranjit,
he,
can you
Anyone can
answer?
answer. He can answer, yes.
Yeah, may I take the liberty?
yes, please.
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 Actually, Dr. Meenu Agarwal, you have brought up an extremely important point, and I'm so glad that you have brought up this point. It is, in fact, extremely important, very important, to store all genomic material. You may not get answers. You may get some further information in the future. Human DNA is extremely sturdy and it can be stored for years and years together. And once we have isolated the DNA, we can run various different tests on them. Something that might not have been picked up by what we call as an excessive test, a wide spectrum test known as next generation sequencing. If we do a targeted PCR, we may be able to pick it up as long as we have the DNA. So to answer your question directly, yes, it is always preferred to store the DNA of the fetal material, once you have sent it to the genetic laboratory. Dr. Millen wants to say something.
Yeah,
Veronica is
thank you
here.
very much. Yes, Meenu, this is really a very important question, which has changed our clinical practice as far as the genetics is concerned. You know what happened? Quite often, our patients, when they come with some sort of actually the problem in obstetrics, they are not necessarily immediately ready for all those investigations which we offer. But nowadays, we started doing the DNA storage for all these patients because which is very economical, and we keep that evidence safe with us on which we can definitely do actually the plenty of investigations as science evolves more and more every day as we see in the field of genetics. Quite often previously there was some limitations for the extraction of DNA, but with advanced technology now I realize that almost all the samples which we send, there's always a good DNA storage which can be utilized in future for further investigation, maybe even after consulting your geneticist, and he or she may offer something additional as well than what you know as OBGYN. So that is a opportunity one all nations should
Yeah,
exploit.
very
Thank you very much.
insightful. Yeah. And Dr.
Thank
Veronica
you.
is here. I think we could proceed.
So I
Thank you,
don't
Dr.
know
Millen.
if Veronica heard about what we spoke about her when she was disconnected, but then I think everybody else heard, so it's okay. And we can go ahead with the Veronica's talk. And uh,
Please share your
you can
screen.
start sharing your screen.
Good morning, respected seniors, and thank you so much for this opportunity, ma'am and sir. And today I'd be discussing about couple carrier screening and the importance of it and why it should be offered preconceptionally to couples. So we'd be discussing about the need of testing, which all tests to perform, and what are the risks to the couples in terms of genetic disorders and risk to pregnancies when we test in the prenatal diagnosis, and options after testing that we have. So carrier screening can broadly be divided into two parts. That is a targeted carrier screening, in which we test and look for only very common genetic disorders. So we pick these disorders depending upon the prevalence of these disorders in the population. For example, that we know that some disorders are more prevalent in certain ethnic groups because of the survival advantage or the founder effect in those groups. So some of these disorders occur more often in certain races. And for example, a sickle cell anemia is most common in patients of African descent. So the sickle cell carriage is also more common in individuals of African descent. So in those people, sickle cell is something that has to be tested for. India has the second largest population with sickle cell carrier rate. So we also test for sickle cell by doing a CBC or HPLC. Another disorder that we have to test for is thalassemia. So thalassemia has been integrated in the guidelines for testing in pregnancy now for a while. And recently, the guidelines have not been published, but we've also included a disorder called as SMA, that is spinomuscular atrophy. So, of course, these disorders are not restricted to these groups and can be present in any population in the world. Whereas expanded carrier screening means that many disorders would be checked using a single sample, and all the recessive autosomal disorders, autosomal recessive or X-linked disorders could be checked at once. So this will give us the opportunity to pick up even rare disorders and even the disorders which are not so prevalent in that particular population. So basically you are testing for most of the inherited disorder. So while counseling, when we say that we can offer an expanded carrier screening, we can tell them that all the disorders which may be inherited and which may be recessive are being checked. So this list is called as a screening panel, and the number of genes, number of disorders that are checked in these panels are different. We can have a 100 most common gene panel to a 2000 gene panel, which will check for a wider variety of disorders. So it is important to check the genes to know that the future is secure for the child, to make the child, he or she, free of genetic disorders through carrier screening. Of course, it is restricted to a group of disorders in which the parents are carriers. Carriers could mean that the parents themselves will not be symptomatic and will not have the disease. But the children who would be born of these parents may be at a risk of having these disorders. So we cannot identify carriers by their symptoms, but only after testing. India has the largest number of people with birth defect, metabolic and genetic disorders in the world. So we have 48 million people with birth defects with genetic disorder, and 1 in 150 children are born with some or the other genetic disease. So, of course, reasons include in India consanguinity, endogamous marriages in the large population. And the biggest definitely is the lack of awareness about prevention of genetic disease. Because the costing of genetic disease was so high, even the aware population could not afford it. But as we can see here, with the advent of next generation sequencing technology, the cost of sequencing has come down by a lot. It has come down majorly, and now this testing is quite affordable to a lot of population. There has been a 500,000% decrease in the cost in the last 10 years due to the advent of the NGS technology, in which you don't have to sequence each gene one by one. You can screen them all together. So the standard practice that remains is to screen individuals who are at high risk of having genetic disorders, that is, a adult or a couple with a family history of a recessive genetic disorder. For example, if there is a family history of a couple with Tay-Sachs disease, we then screen the couple for that particular disease, and also screen the first degree relative of the couples with the disease and partners and relatives of identified carriers. This is also known as cascade screening. So here you will pick up couples with genetic disease risk where there is already a family history, and this is known as a high risk screening. However, in this way, only a minority of carrier couples will be identified, and as the majority of affected children are born to couples with no previously known family history, only a minority of relatives in high-risk family will request carrier screening. Even if there is a child who is affected in a particular family, it is not necessary that the relatives will want to do that testing. So in this way, we pick up a small but significant number of individuals. So now the paradigm is becoming that if a woman or a couple is coming to you preconceptionally, we can offer carrier screening to all these women regardless of age, race, ethnicity. But the important test to offer still remain thalassemia and SMA. Expanded carrier screening can be offered but is not mandatory. Now, which all individuals or which all disorders can we pick up on carrier screening? So here we have a couple in whom one of the gene shown in red is mutated and one shown in white is normal. So these are the gametes that they will form. And out of these gametes, either they will have two normal gametes, one mutated gamete who will be carrier, or in 1 in 4 cases, they will have both affected gamete. And this affected gamete in this case will have the autosomal recessive genetic disorder, and this is the autosomal recessive inheritance. So we can pick up all known autosomal recessive genetic disorders by carrier screening method. And this, but you need to know that how many genes and which genes are they looking for. The other disorder that you can pick up, other type of inheritable disorders that you can pick up include your X-linked inheritance, where the mother is a carrier and she will give the mutated genes to 50% of her sons because the X is present in a copy of 2. So one of two of her sons, that means 50% of son will be affected. And of course, 50% of her daughters will be carriers. So in an X-linked inheritance, only males will be affected and females will remain carriers. So advantage of these carrier screening is to identify carriers of genetic disorders. Carriers sometimes also can develop some symptoms of disease. Offer preconceptional or premarital counseling. Enable patients to identify sources and understand the future of medical management, and help the family prepare for an affected child, even if they don't want to discontinue that pregnancy. In India, most parents do opt for termination of an affected child, as the socioeconomic burden of a child with genetic disorder is very high, and we do not have enough support groups to tell them that your child will be taken care of. So this sort of carrier screening could be done at various levels: pre-relationships, before premarital, before marriage, preconceptional, during early pregnancy when the sperm donor or a ovum donor is taking place. The most common and the most ideal time is preconceptional, but the time that we mostly get these cases or mostly are able to counsel these couples are during early pregnancy. Sometimes during late pregnancy also they come for the same request, but ideal time is preconceptional. So in most instances, as there are only recessive gene, no previously known risks are brought out for the couple. So because they are asymptomatic themselves. But in certain cases, carriers can also have some disease and they may get unfolded later in their times. But now, do we need to counsel about these diseases? So answer is yes. So if you identify a carrier of hemophilia, in your carrier screening, you need to identify and tell the woman about her risk of bleeding and which can be associated with the elective surgery also. If a woman is a carrier of ATM gene that causes ataxia telangiectasia, she will be at an increased risk of developing breast cancer. So that also has to be informed to the woman. So like that, there are a list of disorders where the carriers will themselves be at an increased risk. So what will be the risk percentage in pregnancy? It depends on the disorder in question, if it is a recessive or an X-linked disorder, and the number of disorder the couple is found to be a carrier of. The testing methodologies are just listed here, and it is important that we know them because for a particular test, only a particular unique methodology will work. So for testing SMA and DMD, we order MLPA. One partner, maybe you can order for the female partner. For DMD, always a female partner because it's an X-linked disorder. For Fragile X, you order a TP-PCR. And for CAH, that is congenital adrenal hyperplasia, we order a sequencing as well as MLPA. MLPA is a technology which will pick up deletions and duplications. So all the disorders in which I have mentioned MLPA are caused by deletions and duplications of exon level variants. Now I have listed these separately than the other recessive disorders because they will not be picked up by next generation sequencing based technology. For the rest of the disorder except these four, we can order an NGS-based sequencing test, which is more commonly known as the carrier screening panel. So if you order all these, you have gotten all the common disorders covered. Let us quickly come to some short cases to discuss the relevance of these disorders in practice. So we had a couple, a cousin who wanted to get married to each other. They were first cousins, and that means they were third degree consanguineously married. We know that the risk of recessive disorder is much higher in consanguineous couples. So we offered them carrier screening. They wanted to know about their genetic risks. So there was no gene in which both of them were carriers. But as we can see here, there are some two genes for which each of them are carriers. But we know that they will not have any problem related to these two genes. In addition to this, now we also offered them SMA, DMD, Fragile X, and CAH. So this is a particular situation in which we can tell them that your risk of inherited recessive and X-linked disorder is low, and we will not be offering any prenatal testing related to inherited genetic disorder in pregnancy. So now we come on to case 2. A 7-year-old girl was referred to us in view of diminishing vision and global developmental delay. And the further evaluation and genetic testing revealed that she had this disorder called Alstom syndrome. And Alstom syndrome is a ciliopathy. It causes obesity, deafness, blindness. It's a very severe disorder. So now their main concern was to have another normal, healthy child. And but the question is, did they want their child to not have Alstom again, or did they want their child to be free of any inherited genetic disorders? So, of course, they wanted a completely normal child. So we ordered the testing that I have just listed here: a Fragile X screen, a DMD SMA screen, a couple carrier screen, and a couple karyotype. So on ordering these tests, it was found that both of them were carriers of a gene in addition to the Alstom gene. As you see here, they are carriers of the Alstom causing gene, that is the ALMS one, and also they are a carrier for this ADA gene that causes immunodeficiency, severe combined immunodeficiency. This is how their report looked like, and they were carriers of two genes. So now what does this imply? It implies that the fetus does not have a 25% risk of being affected. It actually, when we statistically calculate, has a 43% risk to be affected with one or both diseases, and a 57% chance to be unaffected. So this 43% is a very high chance, and we offered them the following options: that is a prenatal diagnosis with the 43% risk, in which they have to undergo a termination if any disease appears, an IVF with donor egg or sperm, or IVF with PGT-M as we call it now. So they did pick IVF with PGT-M, and they do have a healthy baby now. So when the disorder risk is very high, IVF with PGT-M, that is testing the embryos, is a great option. In this case, this was the first pregnancy was terminated in view of increased NT and penta screening showing a high risk of T21. And a second pregnancy was terminated here in view of arthrogryposis. And third pregnancy was a first trimester loss. Couple was referred to our clinic for management of the subsequent pregnancy. And a couple karyotype was suggested, and also a carrier screening. So the carrier screening again revealed that the couple was carrier of a RAP-SN gene, which is known to cause arthrogryposis, and both of them were carriers, but this was a variant of uncertain significance. In addition, the wife was also a carrier of an X-linked recessive variant, which was a likely pathogenic variant and which causes hypohidrotic ectodermal dysplasia. That is, the child will not have hair, nails, etc. So in second pregnancy, we were very confused because the variant remained of uncertain significance, and we cannot really have a pregnancy related decision based on that. But we did leave it to the couple, and they decided to go ahead and do a prenatal diagnosis. A CVS was performed. However, there was an acardia, and the pregnancy decided for themselves. So this case discusses that there is a relevance of variant of uncertain significance in carrier screening. If the variant of uncertain significance is not related to your phenotype, it should not be considered in counseling at all. That principle is very clear. If the variant of uncertain significance is related to your phenotype and is fitting the phenotype, then we require a lot of discussion and a literature review whether we need to work on it or not. Important also again is to know that if there are two disorders, the risk just does not double, and we have to calculate the risks statistically if it is a two recessive disorder risk or one X-linked and a one recessive disorder risk, to be able to tell the family for the same and address the parental anxiety and explain the different reproductive options. Now finally, my last case, where a recently married couple came for preconceptional counseling in view of advanced maternal and paternal age. We do not necessarily need to offer a carrier screening, but because they were interested in the same, we offered them, and also they were not able to conceive. So this report here showed that CYP P1B1 is a recessive disorder in which one person was a carrier, so it is not significant. But again, the female was found to be a carrier of F8 gene causing hemophilia, and we know that the 50% of the boys will be affected. And now here in this case, we need to counsel in a different way that there is a list of age-related disorders, maternal age-related disorders including aneuploidy, and paternal age-related disorders including de novo mutations like rasopathies. Also, we have the risk of hemophilia that is present in this child. So, the warning when we discuss about carrier screening is we need to establish the pathogenicity of the variant, Sanger validate the variant, do the factor 8 levels in the mother here so that we are sure she's a carrier, and finally discuss the options in the same. So, the recommendations are that decisions to have any form of carrier screening should be a voluntary and in context to an informed decision. SMA and thalassemia should be screened for all. Expanded carrier screening should be only offered but never mandated. Information about carrier screening should be provided at least to every pregnant patient. If time constraints exist, screening for both the patient and partner concurrently should be considered. Review the benefits, limitation, and disadvantages of testing, which is essential. Family history should definitely be obtained before performing a carrier screening results so that we can focus on those genes as well. Expanded carrier screening does not replace genetic counseling, and that should be available to all of these patients maybe multiple times before they go and opt for this test. If a carrier or a carrier couple is identified, we need to then explain the options, but absolutely leave it to them up to making a decision. So, we obviously attempt for a freedom from genetic disorders, but the first step is really awareness and going on and telling them what are they at risks for. Thank you so much.
Thank you, Dr. Veronica, for a very nice and a simplified talk on how we should go about with carrier screening. I'm sure if we would have given you more time, you could have spoken for hours. But in whatever time we have given, you have utilized the best of the time and shared your insights. Thank you again. And we can move on to the next session.
Thank you, Dr. Saurav Dani, sir, and Dr. Sir, for chairing the session, and Dr. Shyam Desai, sir, for your valuable time. And the faculties, Dr. Naren Malhotra, sir, informative and exhaustive session. And we now move on to our next session. And for this, I invite my co-moderator, Dr. Naima Shareen, to kindly take over for the necessary proceedings. Dr. Naima? Dr. Naima, are you there?
Thank you so much, Dr. Prerna.
Yes.
I'm honored and privileged to be a part of this important session. So I would like to proceed to the next one, that is genetic in infertility panel session. Moderator of our today's session is Professor Dr. Jaideep Malhotra and Dr. Arti Chitrakara. Dr. Professor Jaideep Malhotra, she is known to all and the dream lady of all young gynecologists nowadays. And I would like to introduce ma'am because she is one of the idol of all of the gynecologists of all renowned of all countries. So ma'am is past chair of FIGO, reproductive health and reproductive health endocrinology and infertility. She is president-elect in SARG and past president of FOGSI, Asia Aspire, International Menopause Society, SAFOG and ISPAT. And Dr. Arti Chitrakara, she is ex-senior resident from Obsgyn Department of AIMS, New Delhi. So I would like to request our moderators to start the panel session regarding genetics and infertility and to introduce all the panelists.
Thank you, Naima. Thank you so much. I'll just share my screen, please. So this session is going to be on the genetics in infertility, again, an area which basically is lesser understood, and there are a lot of times when we don't have answers to a lot of questions, and it becomes very, very difficult, to explain to the patient. And I feel the recurrent pregnancy loss was one area which, has really been very well dealt with. And now we will just try and understand why genetics of infertility is really important. So our panelists are Dr. Deepanjana Datta, who is BGCI Level 2 Certified Genetic Counselor, State Coordinator for Organization of Rare Diseases in India, and has 14 years of experience in the field of human genetics. And she's from Calcutta. Now, our next panelist is Dr. Swasti Sharma. Swasti is from Nepal, and she is an IVF specialist. And I know that she has been in the field for a very long time. And our next panelist is Dr. Meenu Agarwal. Again, Meenu is a very renowned person from India, and she is part and parcel of FOXY, ISPAT, ultrasound training, and SAFOG also. She is heading one of the committees. And our next panelist is Dr. Milind Shah. And Milind also has been very, very popular gynec and has been in the various organizations in various capacities. And Veronica, you have all heard about. And my co-moderator is going to be Aarti, a very young and a dynamic person from the All India Institute of Medical Sciences. And we're going to really understand today on how genetics can actually affect infertility and what is it that we really need to know about it. Now, as we understand that about 10% of all reproductive age group is affected by infertility, and the etiology is very heterogeneous. So when we understand about male or female infertility, the origin can be multifactorial. There are various and numerous genes involved. And when we talk about genes, we just shut our brains out and we say, oh, genetics is out of our understanding and we really don't want to think about it. But without even thinking about it, we are not going to be able to, move further on or maybe upgrade our services as it is really required. Now, as we understand, 50% of the causes of infertility are idiopathic, but 30 to 40% can actually have a genetic origin. And that is something which is very, very important. Now, you may ask me why I want to study genetics in infertility. Now, in my own clinic, I would be thinking about solving a lot of these idiopathic cases. I would like to adapt myself to a personalized management of the patient and offer a lot of genetic counseling, which is actually required. But yes, research is beyond our means, but there is a lot of clinical research which we can contribute to, and that is something I would like each one of us to understand today, and that is the aim of this particular panel. And if we are thinking about where genes interfere, the genes interfere everywhere, whether it is pre-gonadal disorders, whether they are gonadal disorders, or if we have like post-gonadal disorders, they interfere at each and every place. Now, normally, what do we really order? In case if we are having, some issues, we normally order one karyotype, which is very, very common scenario in any infertility clinic, to look at the chromosomal rearrangements or, find out certain things. And we sometimes may also order some other genetic analysis like microdeletions in male infertility. But are we really understanding what we are really doing? And that is something which is very, very important for us to understand, because these defects or these disorders can be at multiple levels and they express themselves also in a very different way. Now, as we understood from the first lecture, these abnormalities in the genetic or the chromosomal aberrations can be at different levels. There could be a missing chromosome part or an extra chromosome part or, a rearranged chromosomes, what we call in our this thing as translocations, and they can have a lot of repercussions on the outcomes as far as infertility or pregnancy are concerned. So this brings me to our first case discussion, which Aarti is going to take over. And let us discuss on how we can, put genetic understanding into management of our patients.
Thank you so much, ma'am, for the kind introduction and having me as a co-moderator for this important panel discussion on genetics, which is such a important point where we can, actually improve our clinical approach towards our patients. So we've tried to get some case reviews and case-based discussions where we'll be seeing how we can approach these patients and what are the tests we can offer on genetic basis, and also how do we manage these cases. So let us begin with our first case. So there's a couple with male factor infertility of last 7 years, husband being 34 years old, who had the following sperm count analysis report. So you can see that there is no sperm seen on centrifugation, which says that it's complete absence of sperm count here. So moving ahead with the question, can I have the next slide? Apart from the infertility treatment, keeping in view the severe oligoastenospermia to azoospermia, would you like to counsel or order any genetic test for your patient? Can we have our panelists?
Yeah. Thank you very much. Yes, Dr. Ati. It's really a very important question. Like, we have seen this last 35 years of practice, and in very earlier days, we used to always think about putting only hormonal assay. But now we have realized that yes, there is a lot on the genetic component in cases of azoospermia, especially when we realize about these cases of non-obstructive azoospermia. We need to definitely rule out the Klinefelter syndrome as well, which is very important. And there are a lot of actual derangements which can happen as well in these particular cases. For example, quite often with more advances in the genetics, nowadays we are realizing even the smaller arms of actually all these chromosomes, sometimes they're short or broken and can give rise to the lot of actually the problems as well. And the more actually important thing which all clinicians should know about is sometimes only part of actually the chromosomes are involved, not entirely the all chromosomes. And then that is a real challenge for the clinicians, how to counsel them. So we always advise the genetic panel for cases of oligospermia or azoospermia.
As sir rightly said, so azoospermia is more about chromosomal rearrangements or major defects in the karyotype. One example is being Klinefelter syndrome. Where oligoastenospermia is present, there is more possibility of microdeletions and rearrangements of the chromosomes. So we ordered a karyotype. Can you have the previous slide, please? We ordered a karyotype for this patient, and this is the karyotype report. So as it clearly shows that this patient had Klinefelter syndrome with XXY chromosome. And now let us see how do we approach this patient. So one hallmark for Klinefelter is that these patients have hypergonadotropic hypogonadism. So that is how we get to know that this is a part of the non-obstructive azoospermia. And what are the things that we can offer? Can we have the next slide, please? What are the treatment options available and what you can offer to this patient? Dr. Meenu, ma'am, could you please take this question?
Yeah, okay. So, I mean, of course, we probably have already done his hormonal profile, and if FSH is low, we put him in the category of hypo, and then we are also repeated the semen analysis, and we have done the karyotyping, and we have found out that he's got a Klinefelter syndrome. Now with Klinefelter, if the count, if then will probably ask my embryologist if it is possible to do an ICSI on the semen sample if he can find a few sperms. If not, then of course a TISA or a TESE can be done. And I will probably go for a TISA and give the sample. And if he can find good motile sperms, probably he can do ICSI. We have to counsel the couple, and if we can get a good motile sperm, and we are able to do ICSI and it floats well, and it develops till blastocyst, I think they should have a good outcome in this particular case.
Yeah, what basically we need to understand here is that these are hypogonads. So we will definitely do the hormone profile in all these patients. And
Yes,
second
ma'am.
important thing, after the profile, now this patient had two semen analysis reports. Like in one, there was a very severe oligoacinospermia, and in the other one, there was azoospermia. So now these patients can actually have, if you're finding sperms in the semen sample, or if you're not really finding sperms in the semen sample, we need to think that if very severe oligoacinospermia is there, then also there can be some genetic problems, and that's why a karyotype is a very important aspect of diagnosis. I'd like to bring in Veronica here. Veronica, what would you counsel these patients for? Like, as infertility specialists, all what we can think is, okay, if we are getting sperms with whatever, whether in the semen sample or by a TESE ICSI, can be done, and we'll give the baby. But from the genetic aspect of it, what would you like to counsel this couple?
So, ma'am, the patient is diagnosed with Klinefelter syndrome, right?
Yeah.
If there are sperms available, there is still a high risk of aneuploidy in the fetuses that can be present. So, in this case, in addition to the IVF that you will consider, we can offer a PGTA. So, that will help them in having the aneuploidy ruled out. So, that is something we can offer.
But normally when we say, like, sperm basically would not be carrying as much, because most of these sperms, like whether they are 23X or 23Y, that's why I added this last line, because there's a lot of literature which says that, the risk of aneuploidy in these individuals is not as much. But if somebody is really worried, yes, they can go ahead and do PGT.
Because
Okay.
they are suffering themselves from Klinefelter's a lot, and there is a 2% increased literature risk for these men. So maybe that's why we can.
Yeah, and Dipanjana, what would you like to add on something?
Ma'am, this is a real clinic experience, ma'am. The problem is we are just not only looking at the chromosome number. The problem is also with the fragmentation index that comes in. So when these embryos are formed, they are not really a good quality of embryo as far as even a morphological grading is concerned. So what we do see in most of the cases, if we do a PGTA, there are complex aneuploidies and there are chaotic embryos, and that can lead to poor outcomes. So probably what we are thinking, that maybe a sperm will have just a 23Y that way, but probably there is also something to do with the non-disjunction and the quality of the embryos, like the quality of the gametes that are being produced, and in most of the cases the outcome is not good. Here I should also bring in, which is not a very popular idea, but sometimes the sperms we get can have certain flagellar the flagella of the sperms can have certain indications, like if I'm getting a bifurcated tail, or if I'm getting a coiled tail. So this can also point out to genetic conditions which are additional to Klinefelter syndrome, like a DNH1, DNAH1
What are
genes
you
and all of
basically
that.
implying? What you're implying is that these patients should have a PGTA or uh,
Yes, a
what is the
PGTA
implication?
should be
Let's
recommended.
have the
Yes.
message clear. So what are we implying? Can any one of
Yes,
you
ma'am. A
like?
PGTA should be required. It is not that the
Okay.
embryos will be good. Yeah.
Okay. So many times, we just leave these patients alone after a TSXC, and we don't really bother about a lot of things. So we must bother about all these issues also, because ultimately people are becoming much, much more aware, and they will definitely come back and say that you did not really tell me how to go about it. I'm going to come to a second scenario. Now, this
Yeah.
is quite a common
Can I
scenario.
add one point, Jaideep, if you don't mind? Yeah.
Yes. Yeah.
Yeah. What actually we started doing for that, whatever treatment option actually we are offering them, we document it. Because when the patient goes next door clinic, and suppose, for example, that patient is chosen for the donor semen, the next door clinician may say that, Arey, you don't know about the testing, you don't know about the ICSI. So it is always better that, yes, we have explained both these options, and now the patient is going to choose whatever actually he or she wants, or the couple wants. Yeah. Thank you.
Yeah. So this brings me to our next scenario, which is also quite a common one, where a young couple, walks into a clinic. They've been married for 3 years with primary infertility. All investigations for the wife are normal, but the husband has several reports of azoospermia. Now, his hormones are within normal limits. The scrotal examination says that testes is slightly small and soft. FSH is again normal, 14. TSH is about 2.5, prolactin or about 24, testosterone a little on the lower side, 200 nanograms. And on TESE, occasional sperms obtained which were frozen on a sperm VD, because most of the time when the sperms are very few, you're not able to freeze them in the regular fashion. So my question to our panel is, now before proceeding for ICSI, would you like to investigate anything else? And how will you counsel this couple about the future course, whether there will be any problem with the offsprings or no?
So, can I take this, ma'am?
Yes, yeah, Veronica.
I mean, the semen analysis with the fructose level, was it clear if the
Yeah,
azoospermia is obstructive or non-obstructive?
non-obstructive.
Okay. So, the approach to these two types of azoospermia definitely remains different. In obstructive, we need to think more of a cystic fibrosis genetic disease related disorder. And in non-obstructive, we can go ahead and test for the AZ, FABC microdeletions. So if it is clear that the azoospermia is non-obstructive, we can test the ones mentioned on the screen: AZ, azoospermia, factor A, B, and C related azoospermia, and then we can go ahead and plan for the future counseling of, and the test mentioned here. What now we do is multiplex PCR is one technology, and we can also order a MLPA based test, which will pick up these deletions in a more targeted manner. So those are the tests that we can offer, and depending on the results, we can counsel them. The men with AZFC microdeletions have more of a potential actually to conceive than the ones with A and
So
B.
exactly like before actually doing a TESE, this should have been done. So that,
Yes,
at least we would have known that which are the ones who will have a potential of having a sperm.
yeah.
Uh,
And it is a Y-linked phenomena. So even if the male does conceive, all his boy children, all his male children will likely to have the same mutation or aberration that this male himself is carrying. So that also message has to be clear before they plan a pregnancy.
yeah, Minu. Yeah, Minu, please.
Chromosome
Yeah.
microdeletions.
It is of course a good idea to go for the micro deletion test, because we are sitting in the august company of all the geneticists. But I think just looking at the size of the testes, if testes are very small in size, it is generally end organ problem. And if he has a history of any mumps, measles in the past, or any viral disease, that could be the reason why he's got a oligoasthenoteratospermia. So that the size of the testis again is a very important thing as
Yeah,
clinicians, which we should keep in mind. If the
yeah,
testis
exactly.
is normal in size, either it is post or pre. If they're small in size, it is the testicular and may not be the genetic reason
Yeah.
also.
But in this case, the testes was just slightly smaller than normal, like almost normal, and the scrotal ultrasound.
Right.
So these are very, very good points which you have brought in. And this, which normally in a clinical scenario, we decide on where is, a possibility of obtaining a sperm. So if the testes are almost normal size, either on physical examination or on an ultrasound scan, and but what I'm trying to bring out here is that which are the cases where you should be thinking about the genetic factors, which are very, very important. And that's why I was asking to bring out that if something like that, an azoospermia comes or a severe oligoasthenia spermia is there, we should be ordering a karyotype. That is what the message is, very loud and clear. And in this particular case, if we see, uh, again, doing a TESE or a TISA or an FNAC, sometimes, because it's a futile exercise if it was like a or a B deletion where the chances of us getting sperms are very low. But in case of C, microdeletion, where the chances of getting sperms are there, then whether we are going to do a TISA or a micro-TESE is a decision which we have to take, because micro-TESE will definitely give you a much better chance of retrieving a sperm than a normal FNAC or a TESA. So that is something which was a point which I was trying to drive home.
Can I just add something more
Yes,
over here?
please.
Just
Yes,
as a
please.
percentage, there has been a study very recently from India with Dr. Deepak Modi and the MIT University. So actually, there they have actually done a very calculation where on basis of their sample cohort, just retrieving the sperms, we also need to understand how many implantations will happen and how many live births will happen. And in that study, they pointed out if it is a and a B, the live birth rate, like even if we retrieve sperms from there, is only 13 to 17%. But if we are looking at C, or if you are looking at the D, the later regions, my chances of getting like a clinical pregnancy rate is about 33 to 40%. So I think while counseling, these are also certain features that we should mention, and it becomes important for the person to take a decision that way. So just a small point, because there's small information that is there.
Okay. So, how prevalent are these microdeletions in male?
Yeah. Actually, in azoospermic cases, literature says about 9.7%. In oligospermic, it is 6% males. But quite often what I have noticed, apart from the infertility, many of them they present with the repeated pregnancy loss as well. If at all they conceive, the embryonic development is not there, and they typically develop. They come with the missed abortion. So one need to keep that also in the mind while discussing about the infertility, even the cases of those losses. Yeah.
Also, one more important aspect, there is another study which actually says that what we are following is the European Androgen Association
Yes.
markers. And India has a different recombination rate. These are regions, and there are not a lot of recombination. So when we say this percentage, probably India is missing out on a number of these recombinations, and reports are coming normal. But these people actually might have the Y chromosome deletion, which is not being picked up because the markers are not correct.
Okay. So the next question, which most of the patients will definitely ask when we are counseling, that can I have a normal male offspring if I have this problem?
So,
Yeah.
yes, you can
Yeah,
offer.
Veronica?
Yes, ma'am. So, that can only happen in two circumstances. Either the male is XYY and we have one normal Y chromosome, or we can offer sex selection and or the, on the female, which is also not possible. So, normal male offspring, theoretically, in absence of XYY, for them is not an option.
Yeah, but he can be as normal as the father. So father is
Yes,
also
yes,
apparently
normal.
Yeah.
looking normal, but he just has a microdeletion which could be passed on to the male offspring.
So
Yeah, and
that's
by
what
the
we
time the
normally
child,
counsel.
yes, yeah, by the time the child grows to 25, 26 years of age, I think there will be much more technologies for him to have a healthier child.
So that's exactly
These
what
are
we say, that
normal, yeah.
that in case if you have a problem, then also you could actually have a baby the way your father's had.
Yeah.
Or so that is a way of counseling, and I think Meenu, we have to be more positive. And yes, technology is definitely going to bring us much closer to having better solutions. Aarti?
We can also counsel him, like if you have a male child, then he can get tested after he gets puberty, and sperm freezing and other techniques, like ma'am previously said. There might be some newer things in future they can go on, but can suggest him for those testings also.
Yeah,
And
sure,
to have
Swasti.
this sperm freezing.
Yeah, Aarti?
Okay. Yes. So moving ahead with the other case, which is about the congenital bilateral absence of VAS. There was a young couple, aged 29 years and 25 respectively, who were married for 3 years and anxious to conceive. The female was absolutely normal in all her investigations. The male semen analysis revealed azoospermia. His hormone profile was normal, and on examination, it revealed that normal sized testis. But the VAS was not palpable, and on ultrasound, it confirmed to have bilateral congenital absence of VAS. So this is the ultrasound image which we can see. Could we, Dr. Millen, could you please tell us how you would approach a patient with an obstructive azoospermia?
Yeah, very good question, because again the science has changed a lot. Whenever there used to be a obstructive azoospermia, I remember in 1990s we used to counsel our patients that yes, the surgery would be probably little difficult, and then we'll have to go ahead with the donor insemination program. But with the availability of the microsurgery, now it's so actually possible to join actually that particular epididymo, actually the testicular anastomosis, and quite often we can achieve. But otherwise, with the advances of ART, we can definitely have the sperm retrieval from the testis itself again. But these patients actually need to be again screened for the cystic fibrosis. That is very important, because we have realized that this particular gene is responsible for this particular condition where there is a cystic fibrosis as well as the obstructive azoospermia or congenital bilateral absence of the vas deferens. Yeah.
So
like
as we can see, yes.
Sorry.
Yes.
So when I say this, like in how many patients with congenital absence of the vas deferens would you suspect a genetic involvement? Veronica or Dipanjana?
Yeah.
Firstly, I'd just like to make one more point that now
Yeah.
we have, from the past, I think 7 years back, another gene has been discovered for CBD in addition to cystic fibrosis, that is CFTR. That gene is called ADGR2. So now it is a good idea for us to maybe perform a panel of
Yeah.
some okay. So cystic fibrosis is extremely strongly related to CBAVD, but in 30 to 40% cases, they can be isolated as well. And if there is CBAVD, 80 to 90% males with cystic fibrosis will have CBAVD. So the reverse correlation is more significant, but we need to rule out these two variants and also then check the partners for the same.
So I actually have been told, that cystic fibrosis is not as common in our country. How true is that?
No, ma'am. So we had a study in our center as well, and cystic fibrosis was the third most common recessive disorder after thalassemia and SMA. So when we talk about common genetic disorders are anyway rare, but we have not included cystic fibrosis in our carrier screening, so it is less common than SMA, thalassemia, but still quite prevalent disorder. A carrier frequency of almost 1 in 60, 1 in 50 to 1 in 60.
I see. So these are the two genes basically we are looking at.
Yeah, as
Anything
Dr.
else you would?
Veronica said, ma'am, also this gets in most of the cases this gets misdiagnosed as varicocele, and if we are not looking at the ultrasound of like the right kind of ultrasound, actually the ultrasound pictures only let us know that this can be a CFTR or these mutations can be present. So in our center we have now seen if it's an obstructive azoospermia, we definitely go for these ultrasounds, and if we are seeing those calcifications and those regions, we are definitely testing, and a lot of patients are coming positive.
So can you just little explain like why we should be doing and the problems which are associated with cystic fibrosis and how this can actually have a vertical transmission in these patients? Any one of you?
Yes, ma'am. So cystic fibrosis is basically when we are talking about cystic fibrosis, we are basically talking about a CFTR gene. So this particular CFTR gene, it has both autosomal dominant and autosomal recessive pattern of inheritance. So in case of autosomal recessive, then if the patient is carrying one particular mutation, uh, uh, variant, and if the partner is also carrying one variant in the CFTR gene, there is a 25% chance that the child will be born with cystic fibrosis. Now, there are also features where what we see is that if a person has cystic fibrosis, like say this person has both mutations and they have the CF which is presenting in a milder way, and the female is a carrier, then there will be a 50% chance that all the children would be affected. But here there is something more that should be looked into, is basically there are certain polymorphisms, which is the 5T or the 5TG polymorphisms, which can actually help us understand what would be the severity. Though there are certain gray areas over here, but then when we see these kind of patients and to counsel them for their pregnancies, these kind of tests should be offered, because even a single heterozygous condition of CFTR can lead to certain conditions like bronchitis or pancreatitis. And it is very important when we counsel this that a family history is taken, and if needed then we also test for these polymorphisms to understand the severity. Normally when we are looking at it, it's basically the blocked tubes that we are looking at in the vast difference, but this can have other implications in the next generation or in the other family members. So one is obviously the recurrence risk should be looked into. We should screen the partners for sure, and also we should look into these polymorphic modifiers that can actually define the disease prognosis or the disease pathway. So these three things should be done and counseled before we look at the patient.
Wonderful. So thank you so much for this insight. This brings us to our next case, which is like a male with a hormone profile, which is of suggesting of hypogonadotrophic hypogonadism. Like FSH is 1, LH is also 1, testosterone is also on the lower side, and prolactin is also low. And the patient has come with azoospermia and also has anosmia. So,
So,
yeah, Meenu?
Yes, Dr.
okay.
Meenu.
Yes. Since he is hypo, and he also has a loss of smell, I would keep a possibility of Coleman, but I will not rule out any post-COVID and other things. Sometimes then also they have a loss of smell and loss of taste. So yeah, I will keep a possibility of Coleman syndrome for this
Yeah.
gentleman.
Yeah, so we definitely have to keep a possibility of Kalman syndrome, and I would like our geneticists to explain to us, like, what is it that we need to understand from this, and is there anything in the counseling part which we would like to address?
Panjana, go for it.
Yeah.
Panjana, okay.
Yes. You want me to say, or
Yeah.
okay? So Kalman syndrome is again disease which is on the X chromosome. So it can be X-linked, it can be autosomal recessive, or it can be autosomal dominant. So what we are normally looking at Kalman syndrome is if we get these features where the family says that they can't smell, or there is the hypogonadotrophic hypogonadism with there's certain we look at the olfactory lobes also. So if all of that we are looking at, and we should do a panel testing. In these panel testing there are about 40 genes that can be related to these kind of conditions, and depending upon the mutation we can understand the pattern of inheritance. And in certain cases there can like this is a bit of a complicated one, because in certain cases there can also be copy number variations, and the females can be carriers. So taking the pedigree perfectly, looking at three generation pedigree over here becomes extremely important. Understanding whether the other family members are involved are also very important. So this is where and in this case we cannot do a normal karyotype or mlpa here, because there are 40 genes involved, and we would understand the pathway, but we need to do a panel testing, and hence we go for a exome sequencing in these cases, which can help us understand which gene is there, and then take it further. Depending upon the inheritance pattern, we can counsel the other family members, or whether we need to test the partners, and then go ahead with it.
Is there anything we can do to prevent?
Prevent as in we can do a prenatal diagnosis as per se, or we can do a PGT as per se, but right now the guidelines of PGT are a bit in the gray region, so that is something to think about, because this is not a life threatening condition as per se, but if it
Exactly.
is that way, like the guidelines are right now in a bit of a gray zone, like so we have to discuss it probably with the patients, but this is not a life threatening disorder. Like we were
Exactly.
talking about CFTR, it's a life threatening disorder, there's no confusion over there. But in these cases, these are not life threatening in most of the cases.
Yeah.
If it's one gene, there are certain genes which can cause spectrum of disorders, those we can definitely offer for prenatal and PGT. But if it is just a non-syndromic one, then there are like debates about whether we can offer it or not.
Yeah, basically preparing the couple, for the future, because sometimes when they're not really ready for it, then it can come as a shock. So that's why the counseling is
Yeah.
really
Yeah,
very,
and
very
yeah,
important.
Jaideep, one
Also,
more
yeah.
small question to Veronica as well as Deepanjana. Have you read that paper of this nitrous oxide treatment? What is mentioned
Yeah.
in the slide in the mice? And have you read that paper actually?
Yeah.
I haven't.
Okay, okay,
So
okay,
this is
great. Yeah,
what
yeah.
I have also mentioned here. Nitric oxide
Yes,
treatment can reverse the phenotype of
yes,
NOS1 mutant, especially in the mice, and this can be a potential therapy
therapy.
in
Yeah,
the future.
But these are all research papers which are
Yes.
research
still
papers.
not,
Yeah, correct.
Yeah.
to
Yeah,
come and give
yeah,
it as a diagnostics or a
But
therapy to the patient is a long way.
correct,
I guess
Yeah.
correct.
these are emerging things, but not really there, like not practiced at the moment.
Not in the clinical practice.
yeah,
Correct.
Yes.
Yeah.
So now
Thank
but
this
you.
yeah,
brings
but
me to
clinic,
our
yes, sorry.
next case
Yes.
discussion, which is a newly married couple walks into the clinic with a history of only withdrawal bleeding for the wife, and they're very anxious to conceive. And when I look at the wife, the stretcher is short, there's a little webbing of the neck, the growth is also stunted, the chest is broad, the nipples are wide apart, and there are certain dental abnormalities also seen. And on an ultrasound scan, the uterus is small, and the ovaries are very like streak ovaries, hardly can see. So we did a hormone analysis, and the FSH was 110, and the prolactin is like just normal 35 nanograms. Now, how would you like to approach in this particular patient? Swasti or Meenu, anyone?
Yeah. So I think we'll do a karyotyping for her because clinically it appears to be a Turner's clinically. So I'll do a karyotyping for this girl, and I will also ask the history of sisters, mother, and the other maternal family members if they have a similar kind of look. I have had a patient with three sisters. All three were Turners, and they did not know when they were born one after the other. Only when they reached puberty that the parents realized, my neighbors only, that first daughter came to me had Turners, second and third, all three sisters had Turners. So
Oh,
I
that's
think it's
interesting that
we.
you say that three sisters had Turner, because Turner syndrome is one syndrome which the risk of recurrence is, we don't even give a risk of recurrence because it's completely sporadic. So it's quite interesting. And ma'am, it was confirmed for 3 of them.
Minu?
I think ma'am, she's disconnected.
Yeah.
Okay. But see,
Yeah.
basically, what is issue here is that most of the times when a patient comes with a uterus where, the uterus is going to respond to the hormones we'll give. So most of the times what we do is we will, give priming cycles, bring the uterus to a normal size and do the next part of the treatment is like an egg donation,
Yeah.
and that is done. And nothing else is even screened for. So what I want you to bring out points is why genetic analysis is important. Because this is what we normally offer.
Because
Yeah.
because
I
initially
just like
turners
to-
may have some ovarian reserve,
Yes.
but it falls very
Possible.
rapidly. So if we have turners and there are eggs, we must freeze the eggs and then whenever she wants to have a child. So that is one possibility I can think of why I should know that she is turners, and the reserve falls very.
And
And the,
sometimes in married women especially, they will not be willing to say that they didn't have their menstruation. So, most of the women, they say like 3, 4 women that I have encountered, they will say that they had their periods, but after getting married, their periods, it's irregular.
yeah, that's
And
also there.
yeah, because they don't want to tell their in-laws or
Yes.
anything that they have some defect. So they'll say everything was regular. Now, after getting
Yeah.
married, my period is irregular. So they will tend to misguide us sometimes. And for that also, and for also obstetric complications, that we need to do the Turner syndrome, because after getting pregnancy, there might be few complications. So in order to, tackle that, to avoid that, we need to do the
Yeah.
karyotyping.
Because the aortic arch and the aortic valve abnormalities are common in these, and these are like major causes of maternal mortality. So this evaluation in these patients is very important before you even go about, offering them oocyte donation. And that is one point which I really wanted to bring out, because in pregnancy, the risk of aortic dissection is too much increased, and that will lead to a lot of maternal mortality. Now, another important and not very uncommon scenario is when, a young couple will walk into your clinic. They've been married for like 2 years, both of them like 30 and 26 years old, anxious to conceive. And the wife, this is what you were talking about, Swasti, the complaint that she had regular periods till about 8 months back. But now her cycles are very short and irregular. And for the last 1 year, in spite of trying, she has not been able to conceive. So when we did an ultrasound scan, this is the scan where you can see like just one antral follicle here. The endometrium is also very thin. And the blood reports or the hormone profile, the AMH is very low, 0.1 nanogram. FSH is high, 28. LH also, and then TSH also is a little higher. While the husband's reports are normal. Now, would you like to comment on this, Swasti?
I think she's not.
So nowadays, of course, AMH is very important. So the AMH has already given us a hint, and she's only 30 years old. So low AMH and 30 years, and FSH is 28. So poor ovarian reserve or premature ovarian insufficiency is the thing that comes to our mind. And it is genetic, but like when we counsel the patient, I don't know how much patient get the idea of premature ovarian reserve there. But here, when we say, she'll say, my mother had 3, 4 children. I'm the 4th child, and my sister has already, because I have this case here. She's just 23 years old, and the same scenario, AMH is 0.3. And it's very difficult counseling her, because her sister has children, and her mother, she had born 5 children, and she's I think the 3rd one. So in this case also, we need to counsel her about that premature ovarian insufficiency. And though it says that there's 6-fold chance of the daughter having if the mother has that, I think the Genesis can explain
Throw
that
some
to
more
us
light, yeah.
clearly. Yeah.
Yeah, because it is important that premature ovarian insufficiency, we have to think about premature ovarian insufficiency. It's very, very common in our region. The incidence is almost like 5 times as compared to the Western world. So in the Western world, if the premature ovarian insufficiency prevalence is like 1%, in our country it is 3.5 to 5.5%. So it is a huge increase. And what is important here, again, from the genetic point of view, is that, of course, we can do as an infertility specialist if they are menstruating, if they have a little ovarian reserve, we can do egg accumulation, we can do like, egg freezing if they're not married in the initial part. But what is important here is that, yes, the other siblings, and I've had this very recently, that this girl comes to me for, ovarian oocyte cryopreservation, and her AMH was like just 0.3 at 30 years. And then, she had a younger sister also. So I just told her that, please get an AMH done for your younger sister. And the sibling also had POI. So we need to understand that we need to warn them as fast as possible so that they can take care of their, reproductive health in the times to come. And that is something which is very, very important for all of us as a take-home message. Now, Arti, the next case.
Before we move ahead with the next, in POI, I would like to ask the geneticist, what are the genetic tests and the panel that you would want to offer to these patients?
Yes, Aarti, can you hear me?
Yes, Dr. Vera.
Okay, so just 2-3 things about Turner syndrome and POI I would want to highlight. One is that Turner syndrome, a pure Turner syndrome where all the cells have eggs, so you cannot even preserve the eggs there. All of the attrition of the oocyte has already happened before birth or at birth. But actually, there is really nothing like a pure Turner. There is always a component of mosaicism that is present. So we have to look at mosaic Turner also. Another reason why we should do the genetic testing, because we will be able to look at the component of mosaicism and their ability to have a baby. In addition to the so many systemic complications they may have, like renal abnormalities, 50% Turner girls have some degree of deafness as well. So that is one thing we need to keep in mind. Another thing is that you never do an NIPT in these children, in these women who are conceiving when they have Turners or mosaic Turners. You will definitely get a false positive and lead to a unnecessarily invasive testing that we have to do. So NIPT should not be done in these patients as well. Now coming on to POI, premature ovarian failure, of course, the most common cause is Turner syndrome, followed by Fragile X carriers. So Fragile X syndrome carrier women will have POI, and if they are the premutation carriers, and that is one circumstance that can run in family. And we need to be sure that we test the sisters, mothers, and take a X-linked family history. But here, only the women will have POI, and in that family, the males will have intellectual disability. There are many other syndromes, including blepharophimosis, ptosis, where you see the girls will have small eyes. But all that we can then test together in another test called exome. But Fragile X screening and Turner screening is a first line and must for POI.
Wonderful.
Thank you for those efforts. So our next patient, she had a bad obstetric history where the father, the female partner, both were 36 years old. The first pregnancy was terminated because of a detection of trisomy 21 confirmed on CBS. The second pregnancy was a miscarriage with normal karyotype, and currently the patient is pregnant again and diagnosed with cystic hygroma at 10 weeks. So the CMA, the pregnancy was terminated, and CMA revealed Turner's with a 45XO karyotype. So what is your approach for this patient? How will you offer preconception counseling for the next subsequent pregnancy? And do we have anything to offer from the PGT point of view?
Yeah, actually, this particular patient couple, they have all 3 different reasons miscarriage. Trisomy 21 is not recurrent, so it happened. It could be a random thing. Second was a normal karyotype. And third, again, as it is not very repetitive, it could also be random. So in my opinion, I think it is a bad luck for the patient, but definitely we can transfer euploid embryos just for them to feel more comfortable for the next pregnancy.
Yeah, Veronica, what you would have done?
Unless, yeah,
First, because we have already seen that if we do the couple karyotype in view of the trisomy 21, that's all. And if the couple karyotype is normal, as ma'am said, Turner is not going to be recurrent, and IVF is necessarily not required for this. So maybe couple karyotype at least.
Yeah. So again, like, using the knowledge and the technology in the right way is very, very important, because this couple was offered IVF and PGTA because of the time frames, they were 36 years old, both of them, and they were very, very anxious. So out of the 6 embryos, 2 euploid embryos were found, and a single blast was transferred, and they landed up with a normal, successful live birth. But if had this couple been younger, then we would have, Veronica?
Yes, ma'am, maybe. Then they could have gone for a natural conception and maybe done an
Yes.
NIPT. Yeah.
Okay. So, what is your experience of offering PGTA or PGT in your own clinical practice, Milind? Swasti, Meenu, anyone?
We do offer PGT in our practice, but in Nepal there is only one genetic lab, and
we are now
all the
more or less
samples.
Yes, Swasti is talking, Meenu.
Yeah, and all the samples are sent to India, of course. So, it's a bit expensive. So when we offer PGT to the patients, then sometimes after the counseling and after calculating the cost and everything, most of the patients opt for donor embryos rather than doing the PGT.
Yeah, we are doing yes, we are doing non-invasive PGTA, but again for the patients who are older than 35 years of, there's a lot of noise.
Dr. Dipanjan, can I
Yeah.
request please mute? I think there's some disturbance coming from it. Yeah, thank you.
I think it's Veronica.
Okay. So we are doing non-invasive PGTA for older age group patients, more than 35 years of age. So there we offer them, if they say, okay, we'll go ahead for it, it's fine, because it is an expensive procedure. So most of the patients coming for.
And what about recurrent implantation failure? PGT for
Background,
recurrent implantation
they
failure?
already have done PhD, everything, infertility. If they are older age group, yes. If they are younger with poor ovarian reserve, again, yes. But if they are younger with good ovarian reserve, we have to look for other reasons for recurrent implantation failures. That's what clinically I would think. But I think it's always a good idea to go for a PGTA to get a better implantation rates.
Oh. So I think we have, finished our time. Aarti, I'd like you to wrap up.
Yeah. So we would just want to conclude with a few advancements in genetic testing and infertility, where we have new patient management strategies for men, where we go ahead with ICSI and TC, which we all are aware of, and as very beautifully discussed in the panel discussion, where to offer which kind of genetic testing, whether the patient has to be offered karyotype or MLPA or multiplex PCRs. So thank you all the panelists. It was a very stormy discussion where we have such beautiful clinical approaches and amazingly summarized methods which we can carry home and also apply in our day-to-day practice. So
and there are a lot of newer developments as far as the diagnostic tools are concerned. So we have this high throughput sequencing, which allows analyzing hundreds of infertility genes. You can actually look into But what we really wanted all of us to understand is that the management strategies are not only giving a baby, but we are also looking at the other aspects, like as we have already discussed, that POI patients or POF patients, the siblings can have, issues, the Klinefelters, the success rates, and then the sperm translocation. All of these, we need to have the family problems also looked into from the genetic aspect point of view, because this is a new paradigm which all of us as ART specialists should definitely be looking into. Like, as I said, POF, sisters are at risk. Then Fragile X, sisters are at risk. Then Ozema, we are looking at sisters at risk. So these are the things which I would like each and every one of you to keep in mind when we are treating these couples. Thank you so much for having us. And I think our panelists also brought out a lot of insight into increasing our depth of understanding about the genetic issues in infertility. Thank you, Aarti. Thank you, Meenu, Milind, Swasti, Veronica, and Dipanjana. Thank you so much.
Thank you.
Thank you, Jaydeep ma'am. It was a very high level scientific content based panel. In fact, when I went through the panel discussion questions, I thought I don't know any of them. It is so high intensity, very, very good scientific content. We also learned a lot from this panel discussion. Thank you very much.
Exactly. Yeah. I was about to say that thanks to Veronica and Deepanjana for wonderful insights. We learned actually new things as well. Thank you very much. Yeah.
Thank
Thank you,
you.
Jaydeep ma'am. Thank you, ma'am.
Thank you.
Thank you so much, Madam Professor Jaydeep Malhotra and Dr. Aarti for the wonderful panel discussion session. Now we will proceed to our next panel discussion regarding genetics during pregnancy. This session will be moderated by Dr. Manjeet Mehta and Dr. Seema Thakur. Dr. Manjeet Mehta is Certified Associate Genetic Counselor by Board of Genetic Counseling India, Certified Clinical Laboratory Geneticist, European Society for Medical Oncology, and Associate Member of Canadian College of Medical Geneticists. And Dr. Seema Thakur, she is Director Medical Genetics, Fortis Hospital, Delhi, and Secretary DGF Dwarka in 2023 to 25 session, Senior Executive Member of Prenatal Genetics Special Interest Group, and executive members of Society of Indian Academy of Medical Genetics. So I'm requesting our moderators to introduce the panelists and to start the panel discussion regarding genetics during pregnancy.
Thank you for this, Dr. Naima. And good afternoon, everybody. Welcome to people from across the various countries that are participating. We will be focusing on the genetics during pregnancy. Let me just start off with the introduction of the panelists. Dr. Mitesh Shetty is the renowned geneticist. He is a head of department and consultant at Manipal Hospital, Bangalore. May I have the next one, please? Dr. Purnima Satoskar is obstetrician with special interest in fetal medicine. She is presently the professor and head of unit at GSMC and Nauroji Wadia Maternity Hospital. Very senior and renowned obstetrician. Next one, please. Dr. Pragya Mishra Chaudhary, I think, has not been able to join, but she's been with us throughout the preparation of the panel. Consultant infertility specialist at New Life Test Tube Baby and Center, based in Patna. Next one, please. Professor Sadia Asan Pal is a vice president of the Association for Mothers and Newborns and member of the National Committee for Maternal and Neonatal Health in Pakistan. We are very happy to have such renowned panelists with us from various countries. Next panelist, please. Dr. Naima Sharmin, who you've been listening to throughout. She's from Bangladesh, very senior and renowned obstetrician. Next, please. And Dr. UDP Ratnasiri, who is a consultant obstetrician and gynecologist, a vice president of SAFOG and past president of SLCOG, and also past president of PSSI. Dr. Saurabh Dani, not in this panel. Okay. Welcome to all the panelists. My co-moderator, Dr. Seema Thakur, is again very renowned fetal medicine specialist based in Delhi. She's been introduced previously. Can we have the slides, please?
Are my slides visible?
Yes, madam.
So, a very good afternoon to everyone. And since morning, we have been discussing about the genetics. Genetics, as you know, can be pre-pregnancy, during pregnancy, post-pregnancy. So, as an obstetrician, it is our obligation to understand the genetics so as to utilize this into our clinical practice in a best way. So these are the common genetic disorders in a low risk pregnancy, meaning thereby they never had any history of genetic disorder. And the commonly we are coming across Down syndrome diagnosed during pregnancy. Second common after the NIPT introduction is triple X, double XY, XXY, which is actually 1 in 1,000. Down syndrome is 1 in 700. Trisomy 18, 1 in 5,000. Triploidy and trisomy 13. So these are the chromosomal abnormalities which we are coming across. The commonest copy number variation as far as the during pregnancy is concerned is 22q deletion, which we are coming across in fetuses with cardiac abnormality, even the raised NT. Then we have these single gene disorders, which are about in 20,000 in number. And we see thalassemia, spinal muscular atrophy. Commonly, the skin-related disorder we are coming across, the ichthyosis, the epidermolysis bullosa. So all these are which cannot be picked up through the ultrasound. So you only need the carrier testing. Then few disorders which can be picked through the ultrasound and confirmed by the genetic testing, that is the whole exome sequencing. They are the cystic fibrosis, Noonan syndrome in case of the raised NT, tuberous sclerosis, if you suddenly find in third trimester the rhabdomyoma, achondroplasia, if the short limbs are found after 20 weeks of the pregnancy, thanatophoric dysplasia, when there are short limbs during the very early pregnancy, like in the first trimester, or asphyxiating thoracic dystrophy or short rib polydactyly, where there is a mild to moderate shortening of the limbs. And these are the cases which we can, create difficulty in diagnosing with the non-specific FGR due to the maternal uteroplacental insufficiency. So apart from the genetic disorders, which are divided into the chromosomal, single gene, copy number variations, we have sometimes the epigenetic disorders also, where meaning thereby all the genetic structure is, the aberrations are correct, but it is the regulation which is affected. So we are seeing Russell-Silver syndrome. We published one case of the Russell-Silver syndrome. So in this discussion, panel discussion, I'll be discussing about the Down syndrome, the important highlights, then NT more than 99 centile, because we are realizing that many of the NT 99 centile, the counseling towards the patient is lacking. So many of these pregnancies are unnecessary heading towards the termination. The absent nasal bone is still creating dilemmas, what to do further. Prevention of neural tube defect, because the neural tube is the commonest congenital malformation. The short long bones is a common presentation, and the etiology could be diverse. And pure common single gene disorders like thalassemia and SMA, these are the two common disorders present in our country. That thalassemia, the incidence is about 1 in 4,000, and SMA, as per the Indian data, it is about 1 in 8,000. Since now we were preventing only the thalassemia as a single gene disorder, but currently the SMA incidence, and with the treatments available, it's high time that we should start incorporating the SMA. So we have a new pyramid of care by the Nicolets, that all the pregnancy related complications has to be identified in the first trimester around the time of NT scan, and they include the Down syndrome, the chromosomal abnormality, the thalassemia, the congenital malformations, prevention of preeclampsia. So we have to prepare ourselves in the first trimester only, so as to face the complications and manage the complications in a better way, in contrary to the past. Till now, the major goal of the antenatal screening program was the Down syndrome. And why the Down syndrome is used as a benchmark? Because it is the most common aneuploidy, which creates the maximum burden to the family, because the children are going to survive till the parents are not alive, and that's why it's the biggest burden to the society. So major focus has always been in the Down syndrome. But along with the prevention of Down syndrome, we learned that this screening for Down syndrome can give us a way to diagnose other conditions as well, including the trisomy 18, Turner syndrome, trisomy 13, triploidy. So now we all have learned that there is a combined screening both in the first trimester and the second trimester, and we utilize ultrasound and biochemistry, and we have a dual marker in the first trimester, then enhanced screen, quadruple screen in the second trimester. So Dr. Pragya is not here, so we would just like to highlight that in the first trimester, the detection rate is about 84 to 88%, along with the maternal age, the ultrasound, the beta HCG, and the PAPE, and with a false positive rate of 3 to 5%. And the enhanced first trimester screening with the ultrasound, the detection rate can be as high as 92 to 96%, which includes ultrasound markers, nasal bone, ductus venosus, and tricuspid regurgitation. But currently, there are biochemical markers also included along with the beta HCG and PAPE, that which include the alpha fetoprotein, the inhibin, and the so the most important aspect in the biochemistry is the interpretation. So what is the mom? So the mom is the median value of any particular data. Like for example, here we can see here that the median of 2, 3, 4, the most middle value is the 3. So in a particular screening scenario, suppose a median serum AFP in a pregnant population is about 30 nanogram and a patient's value is 60 nanograms. So her value is 2 mom. So why do we use these moms? Because as you know, in the pregnancy, there are different, at a different gestation, at a different age, there are different values of all the markers. So it's not possible to compare these. So generally a mom is generated and a normal mom is around 1 mom. So if a lady has got 0.5 mom, that means there is half as much as of the PAPE, for example, is usually present that during that week in the pregnancy. And suppose she has got a 2.5 mom, that means this is 2.5 times. So we need a quality control, and the usual normal is the 1 mom. So for most of the markers which we use, the range is about 0.5 to 2 mom. So now we have, I think Dr. Purnima has joined. So Dr. Purnima, would you highlight the markers in the first and the second trimester quickly?
Yes, thank you to SAFOG and ISPAT for the opportunity. As you said, the best screening is in the first trimester, where we will be doing a free beta HCG and a PAP-A. In the second trimester, we would be doing alpha fetoprotein, HCG, E3, and inhibin, because the triple marker is now almost outdated. And by adding the PLGF and the inhibin to this, the 5 markers, that improves the rate in the second trimester. And also that we must remember that whatever screening test we do, the ultrasound is the most important backbone of the screening, because we can pick up many things on ultrasound. The nuchal translucency, which is done at 11 to 14 weeks, and along with that, the nasal bone, ductus venosus flow, and the tricuspid regurgitation. When we add these 3 additional markers, we can improve the screening detection rate till almost to 95%. And with the penta screen using the additional biochemical markers, we are hitting almost 98%. And yes, the important thing is that we can also reduce the false positive rate to some extent.
Yeah. So thank you, ma'am. So this is how we find in different aneuploidies. The moms, which we just discussed, they are the best for the interpretation. Like in trisomy 21, the PAPE goes down, and so 0.5 mom, and beta HCG is around 2 mom. In trisomy 18, both the PAPE and beta HCG will be low. In trisomy 13 also, similarly, both the PAPE and beta HCG will be low. And in the triploidy, there are 2 patterns of maternal serum markers. One is like trisomy 18, which we can see here. In the diganic form, both the parameters, that is the PAPE and beta HCG, is low. And in the diandric, the pattern is usually like a maternal serum alpha fetoprotein for the neural tube defect. So there will be 2 patterns. One is for the trisomy 18 and the second is for the neural tube defect. So this is our first case, 38-year second gravida. And we can see her PAPE is 1 mom, beta HCG is 10.2 mom, so very high, and ultrasound is okay. And because of the raised beta HCG, the trisomy 21 risk is 1 in 83. So, ma'am, so how will you counsel a woman with such a high HCG?
Yes, so first thing is that we have to confirm her dates. We also make sure that she has not had any HCG injections in the last 48 hours, because it could just be an iatrogenic rise. Make sure there's no vanished twin or a multiple pregnancy or IUFD. Then the other differential diagnosis could be molar changes, hyperthyroidism. And of course, we are looking for trisomy 21. So we will be investigating that further. And a small percentage could be even idiopathic. Now,
just summarize what are the anticipated maternal and the fetal complications, which one has to, counsel the lady.
So there was always a belief that with high HCG, there are increased complications. But there has been a large meta-analysis of more than 1 lakh women, which is a Swedish study which came in pregnancy hypertension last year. And they've differentiated the levels in the first trimester from the second trimester. So because HCG is a measure of the function of the placenta, so in the first trimester, an elevated HCG, if we keep aneuploidy aside, it usually implies that the outcome is better. Whereas in the second trimester, if HCG is raised, then there is a high incidence of gestational hypertension, preeclampsia, HELLP syndrome, and all these other conditions, fetal growth restriction, intrauterine fetal demise, and more likelihood of fetal loss or preterm delivery.
Yes. So the second trimester high HCG is more important compared to the first trimester. And particularly if there is associated increased alpha fetoprotein, then there are more chances of the adverse pregnancy outcome, as ma'am has already discussed. So I think next question is again for you only, ma'am. So this is for the causes of the low PAPE, which we keep coming across around 0.2 mom, 0.4 mom, or somebody would say less than 5th centile.
So usually 0.4 we take as the cutoff, and after we've ruled out aneuploidy, we are still concerned about following and closely monitoring this pregnancy, because this patient will be at high risk for early pregnancy loss, preeclampsia, FGR, and preterm delivery. And this is why double marker test still has a value in screening. So NIPT cannot overtake it completely, because this is one of the benefits.
Yeah, very rightly said, ma'am, that this can, warn us about the adverse pregnancy outcome. I am coming across many women who underwent NIPT and never underwent the PLGF or PAPE. Later on, there is a FGR or the preeclampsia. So probably they missed that window for the, EcoSprint. So
and what more advanced that recently is that they have correlated it even to gestational diabetes. And we know that there is
yes. Yeah, so they are low. So we all know about the low PAPE has got Down syndrome or the pregnancy outcomes. Recently, we are coming across many referrals where the PAPE is high, 3 mom, 4 mom. So initially we used to say ki nahi, kuch bhi nahi hota, just don't worry, relax. But we have now realized that there are papers which say that increased PAPE may be associated with the placenta accreta, and those who are working into the field of the fetal medicine and the ultrasound, they know how disastrous a lady to have the placenta accreta. And also there is recently, as we know from the maternal serum screening, there has always been a quest for finding more and more out of the test. So there are the literature which is showing that a little higher beta PAPE in the cases of the 22q DJOS deletion. So that is something new that one must so the
Madam, I would like to sorry.
Yeah.
I would like to just request at this point, we have participants from other countries. Can you share the practice that you all are following in your respective countries, Pakistan, Bangladesh? So it will be good to understand what the practice is like that, like in your country. Dr. Ratnasiri, Dr. Naima, Dr. Sadia, anybody?
Yes, in Sri Lanka, actually, these are not practice because we don't have the chances of termination of pregnancy. So we do the scanning methods, but not going deeply into the karyotyping unless it is requested by the patient. Because routinely we don't have a analysis with the NIPT in our government practice, but when the patients request only, we go for the screening in Sri Lanka because it's not there in the government public sector. It's only available in the private sector.
So, but they are doing all these things. So, in the government sector, in our country also, we may not have this much advanced screening methods, but
yes,
many of the women, they do come if they want that we are also offering. And Dr. Sadiha?
Yes, in Pakistan, also we're not as advanced as you are in the facilities everywhere. So in the private sector and university hospitals like Aga Khan and some other hospitals in the country as well, we have invasive testing and screening as well. But unfortunately, the blood tests, the blood screening tests are quite expensive. And neither the government or in the private sector, most people are unable to afford it. NIPT is available, but expensive. So, yeah.
So the serum markers are like PAP-A is not universally available. Yeah. But there are lots of facilities where we are doing amniocentesis and CVS, while NT scanning is being done almost in every city of Pakistan. Many are certified by the Fetal Medicine Foundation. That's a great help in our country.
So ultrasound has a detection rate first trimester is around 60 to 65%. So probably,
Yeah.
and with NIPT, of course, yeah. So the biochemistry, okay. But in our country, biochemistry is available. Of course, the accreditation part is the FMF that is lacking. But practically, I have realized there is not much big difference in the moms, whether it is FMF accredited or not. So so that is, but this is available all across our country, even in the tier 2 cities, tier 3 cities as well. So now we move on to for the twin pregnancy, and the commonest question arises that what is the best screening for the Down syndrome in twin pregnancy? Can we do second trimester? And there is a vanishing twin, whether we should do the screening, and so which screening test in the pregnancy? So the screening for Down syndrome in twin pregnancy is more complex than the singleton. And it is therefore important that the counseling prior to the testing should be given by a person who is expertise in this area. It is important that the women and their partners should be explained about that there are two fetuses. So the serum screening will give you a single report only, and depending upon whether it is monochorionic or dichorionic, and if one of the fetuses is affected, there may need resort to do the fetal reduction, which has its own complications. So the screening, then followed by if it is positive, then followed by fetal reduction. So all these screening pre-test counseling must be done in cases of the twin pregnancy. So now, ma'am, so how do we do in the twin pregnancy? What is the main difference point between the twin and the singleton?
So in a 35-year-old woman, screening for Down syndrome for a singleton, the cutoff is 1 in 250. For dichorionic, it's 1 in 125 fetus specific. And in monochorionic pregnancy, it's 1 in 250 specific for the pregnancy. It is complicated. I mean, it is more difficult to counsel and, the women who have this problem.
Yeah, so the first most important thing in a twin pregnancy is to determine the chorionicity. It's not that we should just write twin pregnancy. It should be monochorionic or dichorionic, and depending upon the risk estimation is done. So next question is to you only, ma'am. That is how do we go ahead with the DCDA twin pregnancy, the screening?
Yes, so as you mentioned that, the first trimester scan and the earlier scan is very important. So the crown drum length of the larger fetus is used for dating of the pregnancy. Individual risk is calculated for each fetus. The biochemistry needs correction for chorionicity. The NT plus biochemistry gives a 90% detection rate with 5.9% false positive rate at a fixed cutoff of 1 in 100. The DCDA, dichorionic, diamniotic, 27-year-old, 13 weeks by LMP. Is this the case you're giving me?
No, ma'am, it was just an example to show that there are two, because of this is a dichorionic twin. So there are two risks for both of them, the fetus 1 and fetus 2.
Yes.
And the adjusted risk for one twin is 994, and the second twin is 4053. So one is intermediate risk, which we call like 250 in whenever we do any Down syndrome screening, then we divide the woman depending upon the risk number. So it is one in India we are using the risk cutoff can be arbitrary for depending upon your practice. Like in our country we are using 1 in 250 for high risk, 250 to 1500 is the intermediate risk, and less than 1500 is the low risk. So here this woman, the second fetus, is in the intermediate risk because the number is less than 1500. So This because of the intermediate risk, and the NT was around 95th centile. So the NIPT was done in view of the intermediate risk, and this was a high risk for trisomy 21 with a fetal fraction of 4.5%. So now we called up the women and informed her that this is a high risk, but we don't know whether fetus 1 is affected or fetus 2 is affected. So we need to do the amniocentesis separately for both the twins. And the amniocentesis was done. Unfortunately, one fetus was affected, and this was followed by the fetal reduction. So this is the case of the monochorionic twin. Dr. Pragya is not here, but this is a young mother, 27 years, and she was 13 weeks by the LMP, and she was carrying a monochorionic diamniotic twins. And CRL of one was 60 millimeter, and the NT was 1.26, and the second one was 67 and NT 2.1. So more or less, the ultrasound is not abnormal. But when she went ahead with the, the dual marker, combined dual screen, the trisomy 21 is 1 in 37, and PAPE is 0.59, and free beta SAG is 6.93. So in our practice, whenever the risk is less than 1 in 100, like 1 in 50, 1 in 70, we opt to go for the invasive only rather than going for the cell-free fetal DNA. So in this case, she was counseled rightly that you should go ahead with the amniocentesis, and amniocentesis was done only for one twin because this was a monochorionic twin, so they are monozygous. So only one twin was amniocentesis was done. So in monochorionic twin, one has to tell that the adjusted risk is the same for both the twin. And here, instead of doing the single the every NT, rather we use the average NT and the CRL of the larger twin. And discrepancy of the NT is due to the early onset TTTS that can be there, and that's why the positive rate is higher. So here,
Dr. Mitesh
this was for Dr. Mitesh. Yeah. So when we did the fetal, the microarray, and that showed some unexpected result other than the chromosomal, trisomy 21. So is Dr. Mitesh here?
Yes, he is.
Yeah. So can you
could
explain
please elaborate on this report and explain to all our viewers how
this is an important report in the current times. So first one is of the amniotic fluid, and second one is of the father who had a sister with the developmental delay. Rather, they had 3-generation history with, and that's why the father was anxious to get the fetus tested.
So this was not that. So there is a gain in the microarray report. So there is a trisomy, but the size is very
32 MB, 32 MB for one, and the loss is 1 MB. Yes, I added in the last. I just wanted you to explain that this father is a carrier. So how will you, counsel for the father is a balanced translocation? Because here, I would like to explain here that, whenever you come across 2-segment problem in a case of a microarray report, this suggests that one of the parents may be a carrier. Suppose there was only one of this gain or loss, then I would be not worried that, of course, I will do the parental karyotyping, but my yield of the parental balance translocation will be low. But whenever there are 2-segment exchange, then the chances that one of the partners is a balance translocation carrier is high. And we did the parental karyotyping, and we found that the same segment which are involved here, the 9 and the 11, we can see here there is a balance translocation between the short arm of the chromosome 9 and the long arm of the chromosome 11. So this proved that the father is a balanced translocation carrier. They had a sister who had a mental retardation. She has got no congenital abnormality. Then they have the uncles, the aunts who have a daughter. So there is a huge family history, and that's why this family went ahead with the amniocentesis and the karyotyping.
So I would just like to, draw attention over here to the difference between routine karyotyping, what we call as a conventional karyotyping, and a microarray, which we call as a molecular karyotyping. In fact, some people call it as a molecular karyotyping. All of them look at the whole genome. The conventional karyotyping is a very low resolution. It can look at these gross abnormalities of structural, that you can see in that chart in those chromosomes, that there is a translocation between chromosomes 9 and 11. But when you go to the microarray level or the molecular level, you can see exactly how much of a region is extra or is less. What are the genes in that region? What is the size of that region? So that is, the respective role of these two different kind of technologies and the way we can use it in interpreting and in treating the cases.
Yes, microarray is used for the product of conception, and for the couple, it is the karyotype is used. So, Dr. Shetty, can you tell us how do you counsel such a couple who has got now a balanced translocation carrier?
So if one of the couple is a carrier for balanced translocation, so we tell them that they have a 50% chance of having normal and 50% chance of having a abnormality, and every future pregnancy will require a prenatal diagnosis. So how they would like to go about it. So, and if this is identified first or not. And secondly, we usually try to do, earlier we used to do amniocentesis because of the morphology issue. Now we are trying to do CVS also to close the the anxiety in the couple early. But in the microarray, the only challenge would be that we would not be able to identify balance or the normal differentiation between that, but which is not important in the current pregnancy. And then there will not be any ambiguity associated with it. So that's what we usually counsel them. But again, when they have come also, if they come late, then you can do amniocentesis. If they have come early, then you can do CVS also.
Yeah, so we generally do amnio because they're very apprehensive of their risk of abortion. So we generally do amniocentesis. And then we also, there are two types of women, those who have a subfertility and those who have a good fertility. So how do I decide that which woman I would offer the PGT-SR or which woman I would say that, no, I'll do the CVS or amniocentesis? I look at the fecundity or the fertility of the couple. If there is, good fertility, then I tell them go ahead with the prenatal diagnosis. But if there is a low fertility, then I would say that, okay, you are a better candidate for PGT-SR, where pre-implantation genetic testing can be done to identify the unbalanced embryos, and only those who are the balanced one, they will be, transferred. But in this case, there is always a one caution that if we have transferred the balanced embryos, is still we need an amniocentesis to reconfirm, because the PGT in the PGT analysis, whenever we are doing for molecular or the chromosomal abnormality, it is always mandatory to have a repeat prenatal diagnosis during pregnancy, preferably by amniocentesis, because since ages this has been considered to be safer out of the CVS and the amniocentesis, because we have come across, some of the pregnancies where they underwent PGT-M, but this was not followed by the prenatal testing, and the baby still had, the problem. So, and any lab can have this kind of problems.
Now, with the PGT, usually we recommend to do amnio because you are trying to rule out those small possibility of placental mosaicism.
Yes.
So chorionic villi and trophoectoderm going to be same. So amniocentesis is better to get a clarity that there is no mosaicism. So that is what usually PGT need to be followed by the amniocentesis.
Yes, very rightly said. Thank you. So in twin pregnancy, the chorionicity is the most important. Ma'am is there. Purnima ma'am?
Yes. So
Yeah,
in twin pregnancy,
summarize. Yeah.
the first important thing is to know what is the chorionicity, because in monochorionic twins, we are assuming that they are both monozygotic. And in dichorionic twins, 6 out of 7 will be dizygotic twins. So there is still we don't have enough experience with NIPS here. So by tradition, combined first trimester screening is the best modality for screening. And the second reason for this is that the earlier we do the screening and we confirm that one of the babies is abnormal by doing a chorion villus sampling, we have the option of selective feticide in the abnormal twin, and the normal twin can continue the pregnancy.
Yes, thank you.
However, because NIPS has been researched a lot in twin pregnancy, it has been found now that it has an excellent detection rate, particularly for monozygotic or monochorionic twins. And at the moment, the American College of Medical Genetics is saying that that is the best. I'm sure we have a lot of geneticists here, so they will agree that it has the best detection rate, but a little higher for false positive rate, especially for sex chromosomes. But as obstetricians, we are also concerned about the number of invasive techniques and the losses, particularly because these patients tend to be older or have IVF. So at the moment, we are still doing the dual marker test and the NT.
Yeah, so this is a meta-analysis of 12 studies published by the Fetal Medicine Foundation in the White Journal in 2021. And we can see here that the detection rate is 99% for T21, 92.8 for T18, and T13 is 94%. And in the singleton, they almost not similar, 99.7, 97. Just that the false positive rate is a bit higher. In singleton, it is 0.04%, where it is about 3 times higher in the twin pregnancy. So we need to counsel them that the detection rate is as good as the singleton, but the false positive rates are higher. So we may need to resort to the amniocentesis, and in DCDA twin, both the twins will be needs to be sampled. A few words about the vanishing twin, because in the era of the the good ultrasound machines, even at 6 weeks also we get to see that there is one vanishing twin. So here mainly in the vanishing twin, ultrasound marker for aneuploidy screen must be used. And if a fetal pole is visible, then dual marker biochemistry should not be done. But in cases of empty sac, it has been recommended that serum biochemistry can be done. There is a latest paper by the Nicolette's group in 2020, and they say that and why this is not the screening in vanishing twin, what is being affected is because of the PAPE level, and it has been seen that the PAPE is higher even in the empty sacs also. So this paper says कि first trimester screening for trisomy 2021 in vanishing twin should be of the maternal age, NT and beta HCG. One should exclude the serum PAPE because the PAPE remains higher in cases of the vanishing twin.
So, Madam, once again, I would request to invite the other countries, because they said they are doing more on ultrasound and not so much on markers. And then there's another point that I'd like to mention. We will have to just pick and select 1 or 2 cases only, because we are running short of time. So one quick word each on practice in respective countries, Pakistan, Sri Lanka, and then we'll go to the cases. Because you said you are emphasizing more on the ultrasound markers, and practice of these biochemical tests is not so much in your country.
Okay, so I'll go first. Now, I just want to clarify one thing. In Pakistan, termination of pregnancy is possible for limited indications. And it is up to the clinician also to decide whether necessary treatment is required. So, and especially if maternal health is involved. Now, we do ultrasound screening is available, I think, throughout Pakistan in most major cities with certified fetal FMF certified sonographers as well. And we have, because it works out cheaper as well. While the biochemical markers, not all of them are available. So it's unfortunate, but anyway, it also adds to the cost. And majority of the public, 60% of healthcare in Pakistan is private. So people just can't afford. And at the end of the day, once you've done the counseling, many people don't want to have an abortion, even if the fetus is abnormal. So that is also an issue. So why do these expensive tests then? We have to juggle a lot of things here in Pakistan, unfortunately. Yeah.
Just one quick point. No NIPS should be done for vanished twin.
So NIPT is available in Pakistan also, but again, the cost is prohibitive and very few people in private sector go for it.
Dr. Seema, since we will be not able to do all the cases, let's pick and select the best 2, whatever you feel.
So you can do what you have seen the panel. Can you, okay, so NT more than 99 centile, I think we can do. So this is the case with NT more than 99 centile. and which turned out to be trisomy 21. Just we are trying to show that the spectrum of NT more than 99 centile could be Down syndrome, or it could be congenital malformations in raised NT in about 30 to 40% of the cases. And this was a case picked up in the second trimester. With the first trimester was the NT more than 99 centile, and later on the congenital diaphragmatic hernia was picked up in the late anomaly scan. This is a case of Noonan syndrome with cystic hygroma type of nuchal translucency, and this was an autosomal dominant. So this is the different spectrum for raised NT, and I will skip this slide because it's very, very important that the high quality and FMF accredited scan should be done, and there are the very selected guidelines for this. One has to follow this only, and one has to the question is for Dr. Ratnasri. How do you calculate centile in your country?
Yes. Now, especially we have to get the correct count arm length. So we get the count arm length and use the fetal medicine calculator that's available online. So we can get the nuchal translucency assessment with the assessed count arm length with the fetal nuchal translucency. So it will give the centile. So whether it is in the normal range or above the 95th or 99th centile. So it is mainly to get it with the calculator. So when you define the centiles, it is important to, there are two of these, ECOG and the MFM, they give different centiles. So ECOG goes for the mums 1.9 or about 3.5 millimeters, the nuchal thickness, and the MFM goes with the 95th or 99th centile. So in these centiles, then when you diagnose this, there can be some differences. So with that, we have to follow up with the next level. So sometimes we can see increased nuchal thickness and large jugular sacs and the cystic hygroma where you can see some septi, and all these conditions, anyway, the management is similar.
So whenever we have raised NT, we take the family history, then we do the ultrasound for the congenital malformations because there is 30% association, and followed by CVS and amniocentesis. Diagnostic yield of the microarray is about 5 to 10% above the routine karyotyping and counseling. So the first step is to do the CVS by the microarray because this has got higher diagnostic yield. Then there are different structural abnormalities. Sir, would you like to comment?
Yeah, about in increased NT, there can be 30% of these babies can have abnormalities which are like cardiac defects, diaphragmatic hernia, exomphalus, body stalk anomalies, skeletal defects, and some genital and syndromes. Those are the congenital adrenal hyplasia, fetal echinacea deformation sequence, Noonan's, Smith-Lemeli syndrome, and spinal muscular atrophy. These kind of abnormalities can be seen in this elevated nuchal thickness in about 30% of the cases.
Yeah, so a thorough genetic scan at around 14 to 15 weeks or maybe 16 weeks is essential. So what do we tell whenever the NT is more than 95th and to 99 centile? We don't tell them to go ahead with the termination, but we tell them the common associations: aneuploidy in 20 to 30%, microdeletion 5 to 10%, single gene disorders like rasopathy 1 to 2%, and structural abnormality in 30%. And the outcome is 90% good outcome in cases when the NT is around 3.5 to 4.4 millimeter. If it is 4.5 to 5.4, it is 80% good outcome. So we try to give them positive outlook as long as this is around 5. More than 5, we are also quite hesitant to continue because the pickup rate of whole exome sequencing may not be 100%. So the towards termination, we are also at that point of time, unless the lady is very keen to continue the pregnancy, then only we suggest them. If it is around 6 millimeter, generally we are also a little conservative not to go ahead with the further CMA or CVS. So the Dr. Shetty, so the association with the rasopathy in different studies is reported to be about 1 to 2%. So whenever we have the raised NT, or with the associated abnormalities, or there is a consanguinity or family history with the normal microarray, then only we move ahead with the exome sequencing. And when everything becomes okay, like at 12-week scan, if the NT is more than 99 centile and we have done the CVS, microarray is normal, Early anomaly scan at around 16, 17 weeks is normal, and the whole exome sequencing also is normal. Then the couple still asks that is everything is okay? Will I have a baby with normal IQ? So this is a data published in 2021, and in this they have included a total of 203 chromosomally normal fetuses were included in the increased NT group, and 208 in the control group. So the DQ in the increased NT group is 108, and in the control group is 112. So no significant difference. So after everything is normal, a couple can be assured that the outcome is the same as the normal population. So CVS and the anomaly scan, fetal echo, whole exome sequencing, and then the counseling for the increased NT. So increased NT is an indication for further management. It is not an indication for the termination of the pregnancy. So if there is a resolution of increased NT, normal microarray, normal ultrasound, then the parents can be counseled that the chances of delivering a baby with serious neurodevelopmental delay is same as in the general population. Should we go ahead with the nasal bone, Dr. Manjeet? Or you want thalassemia and SMA?
No, let's please proceed. We could do any of the cases. Like if it is, this is more emphasis on the ultrasound, we could do the next case then.
Okay, so this is a case of 38 years old Gravida, and she came to us with the nasal bone not yet ossified, and her combined screen was done, NT was normal. Her combined screen showed PAPE low 0.1 and beta HCG 1.72, and both the trisomy 21 and 80 were more than 1 in 50. So, Dr. Naima, is she around?
Yes, ma'am. Yeah.
Yeah. So what are the ultrasound marker in the first trimester which you would use? Because most of you all are using only ultrasound for the detection of aneuploidy.
Yeah, we are mostly habituated with ultrasound pictures actually, but alongside in the ultrasound marker, we will check the nuchal translucency thickness and the presence or absence of nasal bone, along with the reverse ductus venosus flow and tricuspid flow. But this should be done along with the main dual abnormalities of the PEP, plasma associated plasma protein A, and free level of beta HCG also.
So absent nasal bone is a common finding in the first trimester. So
First
when do you decide for invasive? Because this is a common and we can assure the women. So when do you decide that, no, this lady needs invasive in the first trimester itself, rather than waiting till 16 weeks?
Yes, definitely there should be the associated markers that will be present, and double marker should be abnormal, and the Nichols translucency should be more than 90%.
So in this case, because the dual marker was also abnormal, so we went ahead with the CVS.
We'll
and
go for the we will go for the coronavirus sampling, and we can get the result regarding trisomy 21.
Yeah. So Dr. Shetty, so her karyotype of this fetus suggested trisomy 21. So now she has come to you for the preconception. How do you counsel her?
So we tell them that it is a pre-trisomy, it happened accidentally. Chance of having this again is low, slightly higher than the population. So still it will be less than 1%. So future pregnancy, they can follow the same protocol. If indicated, if they are apprehensive, then after NT scan, they can decide whether they would like to go for a complete reassurance, then invasive, or they can do NIPT. So depending upon the NT scan, the risk is low. So next pregnancy after NT scan, they can decide how we would like to, that small percent, how they are, whether they are okay or they are apprehensive about it.
Yeah, so you don't suggest parental karyotype here, right?
Yeah, no, pre-trisomy, you don't need to do parental karyotype.
When the unbalanced translocation is shown, then only the parental karyotype is indicated.
Yes.
So the absent or hyperplastic nasal bone can occur in 0.1 to 1.2% of the pregnancies, and there is an ethnic variation association between the absent or hyperplastic nasal bone in the second trimester and trisomy 21 is well described as an isolated marker. The positive likelihood ratio is around 6. So sir is not here, but in Indian context, there is a, the perinatology.com, and what we do whenever we find whatever nasal bone, suppose there is a 3.5 millimeter, then we go to the perinatology.com and we measure the nasal bone, and then the the app itself will tell you that whether this is less than 0.7 mom or whether it is less than 5th centile. So accordingly, you can define for your population. And there are two studies. One is from North India and this is from the South India. And these two studies are taken into calculation for at the perinatology.com for our population. And similarly, there are for all different populations, the Chinese, Korean. So they can, anyone, whatever population they have, they can accordingly read the and find out the the hypoplastic nasal bone. So we have also published a cases of about the case of the revisiting absent nasal bone in the second trimester, and we had 26 fetuses which were eligible for inclusion in the study. We only included the absent nasal bone just to avoid the ambiguity, and we found that if it is isolated, no soft markers, no other abnormalities or no biochemical abnormalities, then the chances of the likelihood of the Down syndrome is only when there are associated marker presence. So I think Dr. Pragya is not here, but we are going to take up the another case. This is related to the fetal growth restriction, and this is an ultrasound.
The 45 minutes are over.
Yeah, so I think we can stop here. Or you want me to thalassemia? You can take up thalassemia. This was an important case. Actually, short long bones is I'll just read through this. The take home message for this case was that short long bone is a common presentation in the pregnancy. So what do we tell this could be, this could be related to the skeletal dysplasia, or this could be due to the uteroplacental insufficiency. So measuring how much short is that? So we need to define that how much is the shortness. So instead of talking in the centile, this should be in the cases of the standard deviation. So if a limb is less than -3 SD or -4 SD in the presence of BPD, whether it is around 95th centile or a normal BPD with a narrow thorax and with a femur foot ratio less than 1, that gives us a confident diagnosis of the lethal skeletal dysplasia. So this is the most important. And of course, we need the molecular diagnosis following the prenatal diagnosis or the further termination of the pregnancy. So this is a case of osteogenesis imperfecta. This was born at 37 weeks, and we can see here the bilateral short long bones were, they were short, long bones were short, and look at the X-ray. Hardly you can, understand these bones. So this is because of the decreased ossification seen in the osteogenesis imperfecta, and this is a case of short long bone, and this turned out to be thanatophoric dysplasia. So now, Dr. Manjeet, I think you can take up.
I'll just take a couple of minutes because we've done all these cases wherein the importance of sonography has been there and ultrasound scan. We're just picking up one of these two cases where, which is not picked up on ultrasound scan. So we are all aware that thalassemia is a very common hereditary anemia. It causes iron overload, leads to serious health issues, heart failure, liver cancer, growth retardation, and it requires social support from family, friends, to manage the disease. And the global burden of thalassemia is there for you all to see. Dr. Purnima Satoskar, please. Next slide. Could you just quickly run through what is hemoglobinopathy?
Yeah, so in the thalassemia, there is a decreased production of the global chains, and that may be due to a deletion or a copy number variation. And there can be structural variants like the hemoglobin S, which causes sickle cell anemia, and hemoglobin C, and then some of the milder types which don't have much significance.
And fetal hemoglobin and adult hemoglobin?
Yeah, so in the first 8 weeks of embryonic life, there are different embryonic hemoglobins which starts changing in the 12th week, and hemoglobin F comes into the picture, and that is the predominant hemoglobin until birth. Some amount of hemoglobin A2 is there in the second half of the pregnancy. So
Dr. Naima,
thalassemia will not be possible easily in the newborn. You'll have to wait till about 1.5 years of age to diagnose based on the HPLC.
Dr. Naima, the types of thalassemia?
Yeah, ma'am, we are running very fast. That is alpha thalassemia and beta thalassemia, and it includes thalassemia major and the intermediate. So in alpha.
Okay. Yeah, so Professor Sadia. So why alpha thalassemia produces intrauterine disease?
Sadia ma'am maybe left. She texted that she is.
She's here. She's here.
Okay.
Because the alpha chains are totally lacking and they are required for each hemoglobin. So these babies will be hydropic or they will have an IUFD.
Yeah.
And
So
we have a structural variant. and for the beta and alpha both. Q India, J Meerut, J Paris is for the alpha structure and beta for the D Punjab SND. Dr. Manjit, over to you.
Yeah, this is one case where we had both the husband and wife were carriers. Who could elaborate about how to go about counseling them?
So
Yeah,
there's a
Dr.
25%
Ratnasari?
chance. Yeah.
Yeah.
There's a 25% chance of a thalassemia major in the baby. But when they come to us, it's very important to sequence the gene and to find out what is the defect and not to rely only on HPLC. And when they conceive, then Korean village sampling can be done at 11 to 12 weeks, and you can generally get the result in about 7 to 10 days because you check for the same mutation which is there in the parents.
Yeah, so in this case, the mutation was done and the fetus was not affected. The fetus was just a carrier only. So I'll skip this. Then, so important, Dr. Shetty.
So in thalassemia in general, so it is always important to confirm the diagnosis, whatever blood picture we are getting. So we need to identify the mutation and then only we can proceed. Sometimes the compound heterozygous can give rise to problem with the not a regular mutation. The other thing is that we need to be careful when the one partner is thalassemia carrier and the other partner the HbA2 is on the borderline. So then you have to be sure because sometimes there can be some silent mutation which can be masking this thing, and sometimes the other thalassemia like Meerut and all those things along with the thalassemia, they can mask the A2 level. So you need to be careful with the once the partner is confirmed. So the other partner, if it is possible, then it's better to sequence the gene and confirm that the other partner is not a carrier.
Yeah, I think let's not go to a new case. I would like each panelist to give 2 lines on a takeaway message from your respective specialty. I know we had very interesting cases, but then we have to keep in mind, there's another panel after this. Each panelist, please, two lines
So we would
on
like
your
to
respective
encourage-
specialty, take home message.
We would like to encourage couples to come for pre-conception counseling or at least very early in pregnancy so that this can be done in time and we can have a diagnostic test and then take the steps as required.
Yes, ma'am.
Dr.
So
Naim.
I can say like for NIPT, so NIPT when the risk is high, I won't suggest like to do NIPT. NIPT should be done only if the risk is low or intermediate. So then only in those cases, high risk should be after counseling for the invasive testing. Another thing in the pregnancy, not to jump for whole exome straight away. You have to always rule out chromosomal microarray first. Then only the whole exome you should look into it. Obviously factoring in the time.
Dr. Naima.
Yeah, we should give prevalence on the preconceptional counseling so that we can reduce the chances of such type of abnormal conceptions.
Professor Sadia.
Yeah, I think, we come from low-income countries. Pakistan certainly does. And we really need to keep the costs of these tests in mind and focus our counseling towards the needs of the patient, really. And pre-conception counseling is ideal. However, they don't come to us. Usually they come when they're already pregnant. So during pregnancy, their screening, focus screening according to the finances is very important. And as I mentioned earlier, if she's not going to have an abortion, these values also come in, the religious values. So it's a waste of time. I'm sure you people are also dealing in your own countries with such circumstances. But yeah, excellent seminar. I must congratulate you. I wish we had more
Dr.
time.
Ratnasari, please.
Yes, actually, countries like ours, the low-income countries, the prevention of these genetic disorders are very important, and also awareness among the public and the ways of counseling and the proceeding once it is diagnosed. Also very important to have the system developed. So I think, in the countries, less health budget, you have to improve this area and get into the, proper service provision if you have to, diagnose and prevent these kind of, abnormalities. So thank you very much for inviting
Absolutely.
us.
So, as mentioned in the conclusion, the clinicians working in this field of maternal child health have a huge responsibility.
Yes.
Dr. Seema. So, we close the panel here. Dr. Seema, last words.
Yeah, so as you know, the genetic disorders are common, and prevention is the biggest measure which we, as a clinician, which can do. So, what is the major area of focus? So, the a good high quality ultrasound in the first trimester and the anomaly scan, not only to include the anomaly, but also the growth, the polyhydramnios, the fluid abnormality. So all these can give us, a clue towards the genetic diagnosis or a genetic disorder, and that is the main thing which one can do, because biochemistry is lacking in many of the Southeast Asian countries. But yes, those who have luxury, they can still utilize it, because this also adds to the the existing screening.
Can I
Thank
add?
you to all. Yes, madam. Yes,
Can just a quick comment, because we have a Muslim population in all the South Asian countries, and cousin marriages are so common, and thalassemia incidence is so much higher amongst these families, generation after generation of cousin marriages. And this is not just thalassemia, but other inherited and congenital disorders are more common. So I think I'm a Muslim, and I'm comfortable counseling them that, okay, you married your cousin, please don't get your kids married to, their cousins, unless it's true love. That's a different aspect. But, this is something we should discourage as doctors, regardless of religion, in my opinion.
Yes. And
well taken.
they do come to us also, ma'am, for the counseling, the consanguineous couple. So what do we tell them? We tell them the risk is about 2 to 3% higher compared to the general population. And these days we have carrier testing available for these. So we don't want to discourage them, make them unpleased. We try to help them with the genetic testing. So
So thank you all the panelists. We've had really interesting conversations, and I wish we could just go on and on, but we have to close now. Thank you, everybody. Thank you to the organizers for giving us this opportunity. Dr. Saurabh Dani,
Thank you, Dr.
Team
Manjeet.
ClearNet, over to you.
panelists, thank you. Really.
Thank you so much, Dr. Manjeet Mehta and Dr. Seema Thakur, for the wonderful genetic during pregnancy panel discussion session. Now we will proceed to our next panel discussion regarding genetics after pregnancy. And this session will be moderated by Dr. Saurabh Dani. He is President, Indian Society for Prenatal Diagnosis and Therapy, Coordinator, Strategic Lead and Development, Past President, Association of Fellow Gynecologists, Mumbai, Coordinator, MCGM Newborn Screening Program 2019 to 22, and he will be co-moderated by Dr. Preeta Joshi. And I'm requesting to the moderators to introduce the panelists and start the panel discussion.
Yeah. Hi. Good afternoon, everybody. So I think after a wonderful discussion which we had, now we come to the last leg of the panel discussion. And let me introduce the panelists for the last panel. The first panelist is Dr. Shilpa Kulkarni, and she is a pediatric neurologist working at J.Y. Wadia Hospital. Next. Dr. Komal Chauhan. I think she is not joining. She is a practicing obstetrician and gynecologist in Mumbai, and she's part of the FOXY. Next. Dr. Achinta Disnaike. He is an obstetrician and gynecologist with special interest in fetal medicine, and he is from Colombo, Sri Lanka. Next. Dr. Rajiv Redkar is a consultant pediatric surgeon, and he is a practicing consultant at Leelavati Hospital in Mumbai. Next. Dr. Shimun Marlene. She is a fetal medicine specialist, and she is also from Colombo, Sri Lanka. Next. Dr. Tala Abdul Alim. He is a practicing fetal medicine specialist from Lahore, Pakistan. Yeah. So we have a wonderful panel here, people who are experts in detecting problems before the baby is born. And then we have experts who can manage the baby if the baby is born with some kind of a problem, pediatric surgeons. And if there is a non-surgical complication, then we have pediatric neurologists to handle that. So I think we have a wonderful team here. I see a few less people here. Unfortunately, my co-moderator had an emergency. She is a neonatologist and she had to immediately take care of. But that directly leads me to this question, even unlike obstetricians, even the neonatologists do have certain complications and they need to take care of it. And one of the most common things that we are seeing is metabolic disorders. Some of them can be detected at birth if a newborn screening is done. So I just want to know from, because we have people from different countries, what is the current situation that you are aware of in newborn screening in your country? So we can, on my screen, I can see Dr. Achinta first. So let me start with him. So Dr. Achinta, what is the status of newborn screening in your country? And if you know about other countries also.
Yeah, thank you. And thank you for inviting me for this session. Newborn screening in Sri Lanka is mainly based on a few aspects. One, of course, is screening for congenital hypothyroidism. I'll just share my screen and just few slides that I have. So what we have here in Sri Lanka is that mainly all the newborns who are born are examined by a doctor who is trained in neonatal examination, where they look for congenital cataracts, hip dislocation, and birth defects. In addition to that, for heart defects, mainly they check the pre-ductal and post-ductal pulse saturation before discharge. And also we do the Guthrie test, the heel prick test, but that is mainly for congenital hypothyroidism only. And initially it was started as a pilot project, but now it's rolled out throughout the whole country. The autoacoustic emission test, which is recommended by the WHO, is also going to kickstart, but it's not, the instruments are not freely available. In the private sector, of course, sometimes the option of doing additional testing for congenital adrenal hyperplasia and G6PD deficiency is available. We have a very strong community field level care with midwives and medical officers of health in the community. So once these babies are discharged, they are usually rechecked again in about 1 month's time, where they are again examined for hip dislocation as well as cardiac examination. And recently the WHO neonatal screening packages, they're planning to roll it out for universal right across the country. But at the moment, they're starting a pilot project involving 4 major provinces in the country. So, and they're mainly focusing on the hearing impairment test with the autoacoustic emission test, eye abnormalities for cataracts, as well as hyperbilirubinemia testing using the transcutaneous bilirubinometer. So that is the current status in Sri Lanka. We don't do a comprehensive testing for all genetic abnormalities, but the heel prick test mainly we not checking for inborn errors of metabolism, mainly only congenital hypothyroidism.
Yeah. So the next person on my screen is Dr. Tala. What is the status in Pakistan currently?
Thank you for having me. Actually, in Pakistan, uh, newborn screening is not freely available, although it's available on privately for all metabolic screening and genetic screening for specific condition is available, and it's not very costly. We do about 60 type of newborn screening, costing less than 15,000 Pak rupees. So the report is available within 3 weeks time. And in addition to this newborn screening, we also have freely availability of hearing and eye testing, but it's not available in government sectors. Whatever I'm talking about is in the private sector. So if the patient can afford, they can go for all these type of screening availability.
So, Dr. Shilpa Kulkarni, you have been in a position where you are working in one of the largest neonatal, I think, semi-private setup kind of a thing, where it's partly funded by the government and partly privately funded. And it's one of the premier children institute. And you have been probably in this space where you're seeing a lot of babies who turn out to be problematic because they have probably not been screened at birth. What is your take? How common is screening in India? Is it as good as what Colombo is, or it is better than that, or we have still not been able to reach that space? Because as Dr. Achinta was saying, we have a very strong public community health system in Sri Lanka. And I believe that India also has a very strong community system. But is there newborn screening so commonly done in India?
So, first, thanks for inviting me for this session. I'm at the at the end part of this thing. When patients get diagnosed, then I come into a picture. But yeah, we have a large neonatology department, very large neonatology department, and we have a different pattern. See, we have rural population which do not take advantage of, means they have only primary healthcare centers where newborn screening is not easily available, as against in urban states. I mean, in urban areas, newborn screening is quite, it is available at a quite cheap rate. I mean, definitely congenital hypothyroidism, few of the G6PDs and all those tests are done mostly in government as well as in private, though it is not freely available. It is easily, I mean, it's affordable. It is not, it is less than 5,000 rupees. You can get a newborn screening done for various metabolic disorders, hemoglobinopathies, for congenital hypothyroidism, CAH. All the NICU graduates definitely undergo a hearing screening. Not all nursery patients. So it is not easily, the hearing which has to be universal is not so easily available in our country. And even state-wise, there are differences. So Goa has a program where they had given a lot of metabolic disorders and hemoglobinopathy, CAH, galactosemia was getting evaluated at newborns at a, I mean, it was free of cost for Goa. Kerala had a program, Chandigarh had a program, but it is not uniform in all the states of India. So it needs to be, means we need to implement newborn screening to avoid further damage to the kids, and early intervention will be the best thing. So if we can put it in the, as a policy, it will be great, but it is still not a government policy.
So thanks. And Dr. Redkar, I know this is not a segment, not yours, probably you are more looking into the surgical side, but you are from a very premier institute in Mumbai, Lilavati Hospital. What is the situation you see in a leading private hospital there? Do you have any idea about it?
Yes, I mean, I am a pediatric surgeon. So directly, I don't get into this zone of neonatal screening, but I do keep my eyes and ears open and see what my pediatric colleagues do. And indeed, as Dr. Shilpa Kulkarni mentioned, that we do screening of some diseases, okay, like the thyroid, like the hearing test, like thalassemia, but it is not consistent in all the private institutes. I come from a very premier private institute, but there are various services available in India, which means there are high-end private institutes, there are nursing homes, then there is trust hospitals, and there are governmental institutes. So I think we as a association of people who deal with neonatal issues should approach the powers that be for a routine screening, because I worked in England for about 7-8 years, and it was mandatory that whether the baby is born in A hospital or B hospital, all of them will be screened. And I think we should harp on our governmental authorities to undertake some kind of basic screening. They've done it with immunizations. So they could as well do it with screening. And that is what I think we should march forward ahead. Thank you.
Yeah. So I think as an obstetrician, a lot of times the questions that we come across is, when somebody is diagnosed with some kind of a disorder, newborn screening test, they would often ask if we had got a sonography done, but sonography was all normal. How did this really happen to us? Or we got NIPT done, or we got a triple marker or Down syndrome screening done, and that was normal. How did this baby still have that? So, Dr. Chinta, do you think the all whatever we are doing antenatally as a basic level of care is adequate enough to detect such kind of problems after the baby is born or when the baby is in utero?
Yeah, thank you, Dr. Shiva, for that question. So, I think it's very important that antenatally, especially when we're doing our ultrasound scans, when we're doing prenatal diagnostics, that we tell the limitations of those scans and the extent that we check for. For instance, certain detection rates might be different depending on the anomaly that we're checking for, as well as the person who is doing it, and especially conditions like congenital hypothyroidism and congenital hearing loss, those defects, sometimes we might not be, the anomaly scan, as you said, might be completely normal. So there was an interesting study actually, which was done here when I was researching for the facts, where they tested pregnant women's knowledge and attitudes about neonatal screening while they were pregnant. So how much information do we actually give our mothers during the pregnancy regarding neonatal screening? I think it's very remote. We are mainly focusing on the just the intrauterine life, about pregnancy complications and all that, but we are not actually educating them or giving them enough awareness, I feel, about neonatal screening. So rather than being things, as you said, suddenly get to know that their baby is going to come up with this abnormality, I think it's better that we start educating them about the neonatal screening process antenatally itself and even preconceptional even. But as you correctly said, we have to correctly counsel them about the limitations. Usually when we perform anomaly scans in my unit, we usually give them a information leaflet where they have to go through, especially when we come to cardiac examinations and all that, about the limitations of our study. But all defects cannot be detected, and that I think needs to be told to them very clearly. And once they have the neonatal screening, I guess proper counseling before any testing is extremely important.
So, do you think, Dr. Kala, we should be talking antenatally to the mothers, say, telling them that, after a baby is born, something like a newborn screening test could be advocated to you, and that is something important? Or we should just leave it to the neonatologist to take it forward after the baby is born? Means, do you think priming them antenatally will be useful?
Now, it is our practice just to inform all the newborn screening. I think if they are tuned up for the newborn screening, they are able to listen to the pediatrician and what kind of investigation they should be looking for. I've noticed patients who are not counseled properly antenatally, they're difficult for them to opt for if the pediatrician asks them for any screening like cardiac screening or for the metabolic screening, depending upon some findings. They are very reluctant to go ahead because of they think it should not be happening to their child. So if we told them from the very beginning this limitation of our scan and the background history and what's going on, so they are able to listen to the pediatrician. So I would always advocate for importance of newborn screening.
So welcome, Dr. Shimun. So I'll just bring you up to speed. We just discussed about the importance of newborn screening and what is happening in the different countries across the SAFOG region. And since you have come in, I think let me ask a question to you as well. So what you are discussing is how important it is to talk about newborn screening in antenatal period rather than just talking about it in the postnatal. So I had a very interesting case where we detected congenital hypothyroidism at birth on newborn screening, and the parents just would refuse to accept that this is possible. Okay, so have you encountered? I think you will. I believe you are in fetal medicine, right?
Correct, yes.
Yeah. So, have you ever encountered any discussion with your colleagues who are delivering women, and they're just refusing to accept that how can this happen when we have done everything as per whatever you have told us? The way they talk is that, जैसे means whatever the doctor has told, we have done everything. Whatever test they have told, we have done. Everything is done correctly and perfectly, and all the reports are normal. And still, you are telling me this is a problem. So, any situation like that, have you ever encountered?
Yes, I mean, actually, on a day-to-day basis, it is important that we counsel. That it starts with counseling, really antenatal counseling, where we inform patients that any screening test that we do does not definitely. It's after all, it's not screening. It's not diagnostic. So therefore, we are not able to 100% detect all cases, and they should know the limitations of a screening test, and that certain cases may not be picked up, and also. And for not every congenital abnormality can be screened in the antenatal period. So this information has to be given to the patient in advance, that there are certain things that we can pick up. And even for those that we can pick up, there is a there's a sensitivity for each of those conditions when it comes to them being a screening test. And there are also certain things that cannot be picked up in the antenatal period. So they must be aware of that so that they don't blame the doctors once a baby is born. And also that they should not be under the impression that if they have had a screening test, but be it a screening test in the first trimester for aneuploidy or screening for anomalies in the second trimester, that they are then going to get a perfectly normal, healthy baby that does not have any issues. So that is also very important that they are aware of. And even when they have a perfectly normal baby at birth, that doesn't mean that they are going to be developing normally as well. So they have to therefore have some sort of understanding about screening tests and diagnosis in the antenatal period. And I think that comes to, again, patient education and provision of information.
Yeah. Okay. So one important aspect is before we conclude about the newborn screening is that who do you think should be responsible for getting the newborn screening? Is it the obstetrician or should it be the pediatrician? Now, we do not have a neonatologist on our panel right now. So I think they lose the chance to fight against it. But in your wisdom, what do you think? How should the proper approach to be to see that a baby who is born after birth should get a newborn screening done? So who should be really taking the charge?
Well, in the antenatal period, it is our role as an obstetrician to educate the parents as to what to expect during the pregnancy and immediately postnatally with regard to the mother and the baby, because obviously the parents will only meet the neonatologist postpartum. Unless there is a problem detected antenatally where the mother needs counseling earlier on. So I think it is definitely our role to educate them. It's something something so routine such as newborn screening should be informed well in advance, because we know that we are going to offer this test for them postnatally.
There is this guideline from ACOG, American College of Obstetrics and Gynecology, which says that it is the obstetrician's responsibility to see to it that the information about newborn screening should be made available to antenatal women during their antenatal visits. It could be in various forms. It could be in the form of literature, booklets, posters, or videos, or whatever it is. Now today we have a lot of technology options available with us. And once this information is given to them in the antenatal period, then this babies can, and then the neonatologists or the pediatricians can talk about them as a second level once the baby is born, telling them exactly what we all discussed, that there are a lot of things which are hidden and cannot be detected unless you do a test. So to conclude with this,
can I make a comment on this?
Yes, please.
Can I make a comment?
Absolutely, please.
See, see, when you are talking about new screening, we don't have a practice of involving a pediatrician or a neonatologist in any of the antenatal discussions, unless there is a problem. So priming the mothers or the would-be parents for neonatal screening, it will be difficult from a pediatric or a pediatric neurologist or a neonatologist point of view. And when the baby is born, their mindset is not of a acceptance of doing a blood test of a baby. So if they are already primed by an obstetrician, that would be great. That will be easy for a neonatologist or a I come very late in this picture, but it will be great if
Dr.
obstetrician
Shilpa,
does
we
that
hear you,
basically.
and
Yes,
we
I
are
wanted
hearing.
to add something onto this actually. Now we have these antenatal classes for pregnant moms. And in these antenatal classes, we educate women about what to expect in pregnancy, postpartum, labor, etc. So here we try to tell them about this antenatal newborn screening. And we also try to get during this class to get a neonatologist to come in, or at least one of their team members to come in to talk about the neonatal period, to educate mothers. So this is one opportunity where we can actually educate them. If we can do this sort of across the board to everybody, it would be a great thing. Secondly, I think this patient information leaflets, if we can sort of devise this and distribute it to all pregnant mothers during the antenatal period, that's another way to get this information across during the antenatal, because I know in the UK, they have the patient information leaflets on newborn screening. As soon as you book in your pregnancy, you get that leaflet on newborn screening as well. I think we have two great opportunities. One is during the antenatal class, and the other one is also if we can try and get a leaflet through. If there isn't enough time to be talking about all these things during antenatal appointments, at least we can give this in the form of a leaflet.
Yeah, I think it works well. So, Dr. Shilpa Kulkarni, what is the kind of implication that you have seen because some baby has been having congenital hypothyroidism, not been diagnosed, not been treated, and maybe the baby comes at maybe 3 months or 6 months, are whatever the problems that you see, are they reversible, or what is the kind of implication we see because of congenital hypothyroidism?
See, congenital hypothyroid, basically a thyroid hormone is required for brain development, and it is required from antenatal period also. So for development of a cerebellum and cortex, your thyroxine is very important. So if it is diagnosed late, that critical period is lost, where there is basically all your synaptogenesis and organization of the brain structures and functions is happening in the first 2 years. Myelination, everything is happening. So if they are treated late, there is high chance that they can develop intellectual disability, which may not be reversible. So in neurology, our dictum is whenever it is treatable, you have to try and find it out very early so that you can do early intervention and treat it so that you don't have to, it's an irreversible damage. Once they are intellectually disabled, you can't make that neurons to work like if they were given thyroxine at birth.
Correct.
So it is very important for congenital
Can we
hypothyroidism to be diagnosed at birth.
Thyroid status? Means
Yeah.
is the likelihood of this happening to the child more if the mother is hypothyroid or something? Or is there any relationship or no relationship
So
with that?
usually babies are parasites, right? Like they will take maximum things from the mother at the cost of mother's this thing. So though if untreated mothers also, there is high chance that the cerebellum doesn't develop. So there could be chances of motor delays and other specific brain disabilities which can be there if mother is hypothyroid and mother is not properly treated.
To our fetal medicine team here is that can we detect congenital hypothyroidism on ultrasound or something like that? Is it possible to do that? Can we see the thyroid gland or something when you're doing a soft mark on ultrasound?
No, you can identify an enlarged thyroid, but you can't identify congenital hypothyroidism.
Yeah, so my whole
And
point of
most of them are hormone level or receptor level abnormalities, so may not be picked up on the size of the gland.
the most common cause, almost 85% of the causes of congenital hypothyroidism in a newborn is absence of the thyroid gland. Now, as you rightly said, you can see an enlarged thyroid, you can see a no absent thyroid in the antenatal scans. So it's absolutely normal to not see that and go ahead with it. And that is why these babies need to be screened, because there is no way of detecting this problem antenatally. It can only be detected postnatally as soon as the baby's thyroid starts functioning, and it doesn't function. Then comes another 10-15% of the causes where it is because of the dysharmonogenesis, where there is this receptor level problem and the thyroid TSH is not formed properly. That is another. And rarely what you see is congenital hypothyroidism because of genetic causes. That is less than 1% of the incidence. And that is why mother's thyroid status has no relevance on congenital hypothyroidism. So another common problem that we see is thalassemia. I think the last panel was wanting to discuss thalassemia. They didn't have adequate time to discuss it. So let's take it up for there. So thalassemia is obviously we are screening both the parents. That's the ideal way of going about screening both the parents. But do we really screen both the parents, or we are only screening one of the parents antenatally? So any
Well,
you can take it up here.
Well, in Sri Lanka, we don't routinely screen either parent for thalassemia. What we do is if we diagnose anemia, we would then further investigate for anemia. And then if we think that this could be in the lines of thalassemia, then we would screen. This is if a patient is not known to be thalasemic. And we would then go down that line and screen. And if, of course, one parent is identified to be thalasemic, then we would screen the partner or the husband as well, if one is a carrier. Achinta, do you have to add on to that?
Just to add to that, Shimon, so in Sri Lanka, we have few thalassemia high risk areas, and there are specialized clinics in that area. So if there are patients who are already diagnosed or have known to have thalassemia traits, one aspect is that we offer them counseling regarding, I think Prof. Sadi Ashan was mentioning about having lots of consanguineous marriages and all that. So one aspect that we also do is counsel them regarding having the risk of transmission to the newborn, the thalassemia trait, as well as the thalassemia disease. But it is the commonest monogenic disorder that you get in Sri Lanka. But unfortunately, we don't have a routine screening, as Dr. Shamoon mentioned, for screening for thalassemia, which we universally do for all women.
So we were doing one program in Mumbai on newborn screening, and we found the incidence of hemoglobinopathies in the range of 1 in 75. So this could be any of the different variations which are possible. So it could be thyle major, sickle cell disease, sickle cell traits, hemoglobin C, hemoglobin D, hemoglobin E. So all these different variations, and that incidence was very high at 1 in 75. Now Bombay being a very cosmopolitan population where we have people from all walks of life and different ethnicity, this incidence is 1 in 75. So if we go to more endemic areas, like if you go to Punjab or you go to Rajasthan or if you go to Tamil Nadu or South, there are these pockets, as you rightly said, where the incidence is much higher. Typical Indian tribal population has a very high incidence of sickle cell. So in this, I'm sure the incidence is going to be much higher than 1 in 75 as well. And then if we don't do an antenatal routine screening for the mother, we do tend to miss out detecting them, and then also not knowing what is the status of the father. So I think one thing that change that can be brought about is that we start screening all the mothers antenatally with HPLC, because the idea of doing reactive screening based on CBC or anemia tends to miss out a lot of other variants. So it's possible where this mother could be an hemoglobin E or a hemoglobin C, E or D or something, and that's why her hemoglobin would not go very low. But the father could be a beta, and because you have not screened the mother, you wouldn't know the status of the father, and then you'll get a child with a beta E or a beta D or something like that. And that's why screening the mother with HPLC is very important, because once you know that their mother is normal, at the most what is going to happen is the baby is going to be a trait, nothing more. So, Dr. Shilpa Kulkarni, I would like to bring across this new thought processes which are coming across of spinal muscular SMA screening, carrier screening. Apparently, SMA is being talked about a lot. And one of the reasons why it is being talked is also because the cost of treatment as of SMA is pretty high. So is it because the cost of treatment is high, the way I look at it is it's better to avoid it rather than having it. Because if you have a child with SMA, the cost of treatment is so exorbitant that you may not be able to afford, and you may not even have any government even supporting that kind of a treatment. So what is the best way of trying to see that you do not get a child with SMA? Because there are populations in India which I know where the incidence of SMA is very high in the parents. So is there a way by which we can, I earlier heard Dr. Veronica saying that routine screening for any carrier is not a good thing. Maybe we should not be doing it. But for diseases where the cost of treatment is so costly, it may go in crores, just for treating a child. Do you think we should go ahead with a carrier screening plan? You are on mute. Can you unmute yourself?
So now SMA is getting discussed a lot because there are newer treatments which are available, and if you treat them early, you get better results. So now there are few countries where they have included SMA in newborn screening. In India, it is still not a part of newborn screening because we can't give them treatment, even if we can screen them and identify the disease, but we can't treat them. So parental screening. So if you are a carrier of SMA has a incidence of around 1 in 10,000. So it's quite high incidence which is there amongst the rare disorders. So still, I mean, there are no clear guidelines regarding whether mother should be screened for SMA, and if she's a carrier for SMA, then the partner should be screened. If you ask my opinion, if you can afford, you should do it, because we know that the treatment is still, even if you give treatment at birth, the cost is 16 crores, which it's not a foolproof gene treatment which is available. So if you know that it is going to be there, if you can avoid it, it is best. So I don't know that in India, it is not still a part of newborn screening as a policy. We offer it only for floppy babies at the moment, and parental screening ideally should be done. But I don't know. I mean, fetal medicine or somebody else can comment on it. If I can avoid a baby of SMA to be coming to the womb, it is best.
Okay. Okay. So basically, I'll just summarize this, that yes, it's the cost of treatment is exorbitant. It's not easily affordable. The whole idea should be to see to it that the baby of SMA is not born in the first place. For that, the only option is doing carrier screening. Whether universal carrier screening for SMA should be done or not, that's a question for the future. Currently, I don't think there are any guidelines recommending that. There are some countries in the world which do SMA screening at birth, but that only makes the diagnosis, but it doesn't change anything as far as because the treatment's cost still remains the same. So if the treatment is not being funded by any government or non-profit organization, then it's not going to be very easy to take care of that child. So coming back, let me go back to our fetal medicine. So, Dr. Tala, what is the most common correctable congenital anomalies that you see in your practice when you are doing antenatal scans? So, typically, which are the most common things where you say, for this, we don't need to abort, we can let this baby come out and we will operate on them. And then you can hand over that baby to Dr. Rajiv Redkar and he will operate successfully on them and everybody is happy.
Now, it depends on this prenatal scanning. We start from the head to downward, like
yeah. So let's look at the most common things, which are
the most common is like omphalocele in the absence of any chromosomal abnormalities. Once we excluded that, then diaphragmatic hernia after excluding chromosomal abnormalities, and these Hirschsprung disease, if we diagnose, and renal tract abnormalities without compromising the renal function. So these are most commonly we can encountered, and we hand over these patients to the pediatric surgeons. And most of the time the outcome is quite good.
So when you see a problem antenatally, do you involve the pediatric surgeon for counseling, or even Dr. Redka can step in. Has he experiences where he's been called by a sonologist or a gynecologist? Hey, this is what we have detected antenatally. Let us together sit and counsel about this and share what is going to be the future course of action for the child.
Yes, we always involve the pediatric surgeons and take their opinion. So the patient also aware who's going to look after them and what would be the prognosis after the surgery. So there's an informed decision about whether to continue the pregnancy or to abort, or if they continued, what would be the options left after the delivery. So the pediatric surgeon is always involved.
Yeah, can I?
Yes, sir. Please
Yeah.
go.
So I think it may be important because usually the parents are very young set of, it's a young couple who has a long list of questions, and thanks to their information that they get from the internet. Okay, so we need to have concrete information given to them about their future baby. Now, this is difficult for an obstetrician to do and for a pediatrician, because normally these cases are handled by a pediatric surgeons. So they will have questions like, will it be life-threatening? How long will be the hospital stay? How much will be the cost of the surgery? Will the child be able to be a normal functioning individual in society? What is the length of life? So all this we tend to counsel them before, and it certainly helps after the baby is born. Now, amongst the commonest problems that you referred to earlier, I felt that the pelviureteric junction obstruction, is a very, very innocuous problem, which is most commonly detected antenatally. And all that ought to be done to the parents is reassurance that 90% of these will get normalized by the time your child is 1 year of age. So it is so heartening to know that instead, if the parents are told that your child has a kidney obstruction, the mother and the father will spend sleepless nights. So 90% of these children get better by 1 year, and the 10% that don't, we do a very simple operation called pyeloplasty, which is completely curable for the kidney, and there are no issues of life-threatening episodes with this child. Thank you.
Yeah. So, yeah, and yeah, Dr. Shimon or Dr. Achinta, if you can share any other common antenatal problems that you have seen.
So I think cleft palate is another issue that we see, then club feet. So that's another one. So these are all correctable abnormalities that in the antenatal period that can be identified. And I quite rightly agree with the rest of the panel members who said that the most important thing is to have a multidisciplinary meeting when a problem is identified with the neonatologist and the pediatric surgeon, so we can properly counsel the patient, because as obstetricians, we may have limited information regarding the prognosis and the course of the treatment as well, and how it's been done. And patients, they demand specific information. You can't be very vague, because they really want to know exactly what's going to happen to the baby, how it's going to be done, how long does it take to actually get corrected, and they really want all that information properly. So at the first instance itself, when you diagnose, it's very hard to even give that information.
So one question which came to my mind from what you just said is multidisciplinary approach. Is that multidisciplinary approach means that the main obstetrician who is dealing with that patient, he talks to the people concerned and then counsels them, or you have all of them sitting on the table along with the
No, I mean, at the time of diagnosing, usually it's either the sonographer who picks it up and then refers to the fetal medicine team, and the fetal medicine confirms the diagnosis and looks and makes sure that other things are excluded, like an associated chromosomal or genetic abnormalities, and just basically redoes the anomaly scan and then confirms that diagnosis. And then you'll have to obviously then break the bad news to the parents. But then you'll also then have to tell that we are now going to arrange a meeting with the team, with the surgeons and the neurologists, the neonatologists. And then we'll talk to you about, because they are going to ask the obstetrician, the fetal medicine team, for answers. So generally the fetal medicine team has some answers already prepared with regard to each anomaly as to what to expect. We should have some basic knowledge. as to what to expect, but then the detailed counseling has to take place with the team.
Correct. And only one thing is, I'm sure this must be happening, but before we speak to the patient, there should be an internal consensus as to who is going to speak what and what part of the treatment is they are going to, because it should not appear to the patient that there is a discord even between the team members itself, you know, so everybody's on the same page, I guess.
Yes.
I think just to add to that, yeah. So as Shimon correctly said, we have a counseling session with the patient. I think usually they are referred to the fetal medicine unit because an obstetrician has suspected some abnormality. So they already come with a mindset that there is some problem there. And when they come to us, one thing is we confirm it or find out what exactly it is. That sometimes thing is that there are certain soft markers which are not that significant also. And as correctly mentioned before, we don't want them to have sleepless nights for days throughout their pregnancy by unnecessarily stressing them out. So telling them the correct facts, and also once we confirm the diagnosis, I think what a challenge is to show that the positive aspect is that since we have diagnosed this, we can collaborate with the pediatric surgeons, the pediatric unit, and show the positive side of it, especially when counseling, so that we are prepared when the baby is delivered to address the needs of the baby. So that is an important thing. And as we were talking repeatedly about information leaflets, I think we have to have information leaflets for the common abnormalities that we detect, so that patients can get more information about it. Sometimes they have to come back with their partner or someone else to have another session to talk about the abnormalities. And some abnormalities, we have to monitor them throughout the pregnancy to see their progression and all that. So it's a kind of a continuous process throughout the pregnancy, and definitely we have to use get the help of all specialties, pediatrics and pediatric surgeons alike, as well as geneticists as well. Yeah.
So we are in the last.
Can I just make a small comment, Saurabh, here? See, in some cases, like especially if there is a diaphragmatic hernia and you pick it up antenatally, it may be wise to shift the mother, we call it in utero transfer, to a center where there are quaternary level pediatric NICU and pediatric surgeons available. So in utero transfer also can be contemplated in some patients where it may be deemed appropriate when you pick up a problem antenatally. Thank you.
So before we just wind up, we are in the fag end of the discussion. There are some anomalies that we see antenatal period, like maybe there is dilatation of the renal pelvic system, or we could see that there is a hydrocephalus. There are some things which are very easily obvious that we'll go to correct it. But the point is, in some situations, the question is not about correcting, but about what is going to be the functional effect on the child. So, is there any way by which we can say, or this is just going to be an empirical data kind of a thing that, okay, so many percentage is going to get this and this percentage is going to get this, you know? Because if there's a hydrocephalus, how do you know that after doing a shunt or a repair and this baby is going to have become neurologically normal? Because these are important things to discuss with the parent, because based on this information, they will decide whether to continue with the pregnancy or end up with a termination.
This answer is for me or for Dr. Shilpa Kulkarni?
I think it will start with antenatal because that is where it starts.
Okay.
And then Dr. Edgar will say, okay, yeah, I can repair it. But then Dr. Shilpa Kulkarni will say that, I don't know how the outcome is going to be. So, yeah, I think
so it depends upon at what age you are going to.
Yeah.
So shall we start?
Who is answering?
Yes. If you all three agree, you three are fetal medicine. If you three agree, anyone can just take it.
One thing is that it depends on whether it's an isolated abnormality, as Shimon mentioned earlier, whether the ventriculomegaly is isolated or whether it's a part of a larger thing like some syndrome. And again, we assess the severity of the ventriculomegaly, whether it's mild, moderate, or severe. So severe the ventriculomegaly, the chances of having some neurological impairment is going to be high. Whereas if it's mild ventriculomegaly, the chances of having some neurodevelopmental delay in the long term might be as small as 10% usually. And it's so you usually classify ventriculomegaly if it's more than 10 millimeters when we measure the posterior bone. So if it is 10 to 12, we consider it as mild, and if it's going above 15, it will be considered to be severe. So assessing the size of the ventriculomegaly as well as whether there are any other associated syndromic features would be one way that we start the counseling, and to see what is the impact regarding long-term neurodevelopmental outcome.
And Dr. Ryu Redkar, would you operate on them immediately at birth, or you would wait for a certain period of time?
No way. The hydrocephalus, there are two criteria for operating them. When they are born, the bones of the skull are not fused. So the pressure is not directly transferred to the brain. So it is allowing the brain to expand. So it is not a surgical emergency. We monitor with their fundus because the retina is a direct reflection of the pressures of the brain. So if we see there is a fundal problem, then we may intervene early. But I tend to wait. I wait for them to declare themselves that they are not going to improve by waiting. And if they are not showing any eye changes or neurological changes, then I would continue to wait until the bones are fused and then address them by 1.5, 2 years of age. So there is no hurry in my management for these patients.
And Dr. Shilpa Kulkarni, what is the kind of experience that you have, the outcomes? Are they neurologically 100% like other non-affected children, or there is some kind of a degree of affection?
You're asking me?
Yes, I'm asking you. So if after they have been physically corrected, do they have any neurological symptoms? Do they need any kind of therapy or something which is required to make them, or nothing is just required? They're absolutely fine.
So see, as Dr. Achinta said that those who are only ventriculomegaly and which are mild ventriculomegaly, isolated ventriculomegaly, 90% of them are neurologically, they do well. Okay, they may have mild developmental delays, but they catch up. So most of them, which are between 10 to 12 millimeters ventriculomegaly, isolated ventriculomegaly. Now, most of the times ventriculomegaly, we need to monitor it because it depends upon at what age you are diagnosing it. If it is early and you are monitoring it and it is increasing in size, it is a matter of concern. You can use something like fetal MRIs to find out any other associated abnormalities to help them know more about the neurological abnormality. So usually fetal MRIs are done between 22 to 24 weeks of gestation, and which may give you little more insight about the corpus callosal abnormalities, posterior fossa abnormalities, which may be missed on a neurosonogram. So, and once 22-24 weeks is over, it's already, you cannot go back and decide to abort the baby. You know that these things are so you need to monitor them. So you have to see the size, how it is increasing, the hydrocephalus, the cause of the hydrocephalus, whether there is aqueductal stenosis or whether there is some other spinal malformation along with it. So you need to involve neonatologists early. Again, in utero transfer would be better, and institutional delivery will be a better option for these kids because they may go into perinatal depression because of the large size and the the delivery part of it. So if they are monitored and a neonatologist is involved earlier in the management of this patient, it becomes easy. And then depending upon means what is the type of the hydrocephalus, if you are intervening early and you are giving them early intervention in terms of therapy and all, you can help them overcome their disabilities. It's a political answer.
So no, that's absolutely fine. So thank you, panelists, for a wonderful discussion and insights into what you have been doing across in your region, in your place of practice. And it was wonderful discussing with you. And I hope you have a good time and everybody learns from it. I'll hand over the stage to Dr. Naima, who will take the proceedings further. Thank you very much.
Thank you so much for calling us.
Thank you very much. Thank you.
Thank you so much, the moderators and panelists of the wonderful discussion session regarding genetics of pregnancy. Now, again, I would like to call upon Dr. Saurabh Dani for his vote of thanks.
I would like to thank, start with the organization of SAFOG, Dr. Shyam Desai, Dr. Jagdeep Malhotra, who have been very instrumental in bringing these two organizations together. I believe from the time we have taken the reins of ISPAT, we have been always trying to get more and more associations to work alongside so that we all can discuss matters of common importance. And as soon as Dr. Jaideep Malhotra heard about it, she immediately said that yes, this is something that we will do with SAFOG. SAFOG is absolutely interested. And that's how she started the ball rolling. And from there, I think this is what this has been a classical presentation of all the efforts she has been putting along with the whole team. Ravi has been very instrumental in communicating with all the faculty members, and along with Manjeet, who has done most of the hard work, where I have just been giving suggestions and comments, and she's actually been doing all the hard work. So I cannot thank myself, but I will definitely thank the secretary and all the faculty and the delegates who have been attending here. And we will see that this whole program is uploaded on our YouTube channel. It will be made available for people who have not been able to, or you want to go back and listen to it again. And once it's done, and Clarinet has done a wonderful job of making this a very seamless thing. I'm sure we can always improve on whatever has happened. And I think we can continue with the phase 2 of a similar program again with SAFOG on some other topics of importance. So thank you everybody for being here.
Thank you.
Thank you, Saurabh, Manjeet, and everyone. It's really been a fantastic deliberation. And I'm very sure, because I already have requests coming in to repeat the program for those of you who could not really join, and do some more interactions. Wonderful. Very, very proud of each one of you.
Thank you so much for the opportunity.
Thank you.
Thank you, ma'am.
so
It's all
much,
because
ma'am.
of you.
Rajiv,
And
nice
thank you, everybody who participated.
Bye, bye, bye.
Yeah.
So we are here ending of our program, and nice to see you all again. Thank you so much. Have a good day.
Thank you, Naima. Thank you, dear.
ma'am.
Thank you so much.
Have a
And
good
thanks
day.
to Prerna too.
Thank you so much, everyone. With all your permission, I'm closing the session over here for today. Thank you.